حفل هذا الملتقى. الله يحييكم، وأكرر أيضاً دعوتي المستفيضة بالترحيب لكل زوار ورواد هذا الملتقى بالتفضل إلى القاعة والتكرم بأخذ المقاعد والهدوء لقرب بداية حفل افتتاح ملتقى نموذج الرعاية الصحية الحديث 2025. الله يحييكم. الله يحييكم مجدداً في ملتقى نموذج الرعاية الصحية لعام 2025. نرجو من الجميع السيدات والسادة الحضور في هذا الملتقى التكرم بالدخول إلى القاعة الاحتفال، وكذلك التكرم بأخذ المقاعد والهدوء لقرب انطلاق حفل الافتتاح لهذا الملتقى. الله يحييكم.
اوكي ستاند باي جو. سلام الوطني. سلام الوطني.
السلام الوطني. رؤية واستراتيجيات، أحداث وملتقيات تؤكد عزم المنظومة الصحية لمواصلة تحقيق المستهدفات في رحاب شركة الصحة القابضة وبرعاية معالي وزير الصحة رئيس مجلس إدارة الشركة الأستاذ فهد بن عبد الرحمن الجلاجل. أقدم لكم 20 تحية سعادة مساعد وزير الصحة ومتحدث الصحة الرسمي الدكتور محمد العبد العالي، ولكم أصحاب السعادة أبناء المنظومة الصحية ضيوف المملكة الدوليون أيها السيدات والسادة. 20 ما الذي يذكركم به هذا الرقم؟ هذا الرقم هو مجموع تجمعاتنا الصحية حول المملكة ضمن نموذج الرعاية الصحية الحديث. وإن كان هذا الرقم قد تضاعف بفضل تضافر الجهود ما بين أبناء المنظومة بل أبناء الخدمات الصحية ككل في المملكة، إلا أنه يظل رقماً يضاف لمظلة تحتوي على محاور استراتيجيتنا الثلاث: صحة بدنية، صحة نفسية، وكذلك صحة مجتمعية. بحجم الأثر الذي تصنعونه عبر نموذج رعايتنا الصحية الحديث، أرحب بكم في ملتقى نموذج الرعاية الصحية الحديث 2025. أصحاب السعادة، أيها القادة، السيدات والسادة، على ضوء مراحل التحول وقياس المؤشرات وما حققته استراتيجية تحولنا في القطاع من مستهدفات، يلتقي عالمنا الصحي على طاولة تجمع صناع قرار السياسات التشريعية بالخبراء المحليين والدوليين، وكذلك بصناع القرار في المؤسسات الخاصة الصحية. نناقش، نلتقي، نتحدث على مسرح واعد بطرح التحديات، بعرض الفرص والممكنات، بمناقشة التطورات. واعد بلغة الحوار التي تحدد المسار نحو بناء منظومة مجتمع صحي إنساني سعودي عالمي مزدهر ومستدام. معكم نعزز جسور التواصل، وبكم نرسم خارطة المستقبل لأن نكون جزءاً من صناعة تحولنا الصحي بقيادة المملكة، بقيادة سلمانها وعزم محمدها. أصحاب السعادة، أيها السيدات والسادة، أنظمة الرعاية الصحية ومساراتها في دقيقتين نتابعها عبر هذا العرض المرئي. نتابع.
المحافظة على صحة الإنسان في طليعة اهتماماتها ومقدمة أولوياته. لذلك أؤكد لكم حرصنا الشديد على توفير ما يلزم المواطن والمقيم في هذه الأرض الطيبة من دواء وغذاء واحتياجات معيشية.
تحقيقاً لمستهدفات برنامج تحول القطاع الصحي أحد برامج رؤية السعودية 2030، انطلق نموذج الرعاية الصحية الحديث في عام 2017 كركيزة أساسية للتحول الصحي في المملكة العربية السعودية، ليقدم مفهوماً مختلفاً للرعاية الصحية يتمثل في رعاية متكاملة ومستدامة، ويتمحور حول الإنسان، ويلبي كافة احتياجاته النفسية والجسدية والاجتماعية.
النظام الأساسي الحكم في نص واضح وصريح أن الخدمات الصحية تقدم للمواطن مجانا.
وقد جاء نموذج الرعاية الصحية الحديث استجابة للتحديات الصحية والأمراض المزمنة التي تستدعي بناء منظومة استباقية تعزز الصحة العامة وتركز على الوقاية قبل العلاج. ويقدم النموذج 6 أنظمة صحية شاملة تغطي كافة جوانب الرعاية الصحية للفرد في جميع المراحل العمرية، بهدف تحسين جودة الخدمات الصحية وتسهيل وصولها لأكثر من 28 مليون مستفيد ضمن 20 تجمعاً صحياً في جميع أنحاء المملكة. بدءاً بالرعاية الوقائية استفاد منها 9,500,000 مستفيد. الرعاية الاختيارية قدمت حملات الفحص المبكر 28 مليون فحص، مما ساهم في تحسين فرص العلاج والشفاء. رعاية الأمراض المزمنة 26 مليون مستفيد. الرعاية العاجلة خدمة 7,400,000 مستفيد. رعاية الولادة الآمنة ساهم التطور في التدخلات الصحية تحسناً بلغ 82%. الرعاية التلطيفية سجلت 21,000 مستفيد. رحلتنا نحو الارتقاء بالرعاية الصحية المتمحورة حول الإنسان مستمرة، تماشياً مع توجهات قيادتنا الرشيدة التي تؤكد أن الإنسان وصحته وسلامته أولاً.
باسم أبناء ورجالات وسيدات أيضاً هذه المنظومة الصحية، أرحب بهذه اللحظات بكلمة الرجل الذي يعد هو صاحب مبادرة برنامج نموذج الرعاية الصحية الحديث، وهو الرجل الذي شكل وجهاً مألوفاً وصوتاً معروفاً رافقنا طوال أزمة كوفيد-19. رحبوا معي بالرجل الذي عرفتموه قبل أن أقدم سعادة مساعد وزير الصحة ومتحدث الصحة الرسمي الدكتور محمد العبد العالي.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. أصحاب السعادة، إخواني وأخواتي الحضور الكرام، السلام عليكم ورحمة الله وبركاته. سعيد أن أكون معكم اليوم في هذا الملتقى الذي تنظمه شركة الصحة القابضة ويرعاه صاحب المعالي وزير الصحة رئيس مجلس إدارة شركة الصحة القابضة، وباسمي واسم كافة القيادات ونرحب بكم جميعاً ضيوفنا من خارج المملكة العربية السعودية ومن داخل المملكة العربية السعودية من مختلف مناطقها المتواجدين في هذه الأيام التي ينعقد فيها هذا الملتقى المبارك في نسخته الجديدة التي تنظمها الصحة القابضة. ونسعد أن نكون شركاء معهم جميعاً في هذا الملتقى من كافة مكونات المنظومة الصحية، بل وأبعد من ذلك، فهنالك كثير من الشركاء لنا في تقديم نموذج الرعاية الصحية الحديث. نموذج الرعاية الصحية الحديث بأنظمته ومساراته التي تنمو يوماً بعد يوم، والتي تخطو خطوات واضحة ومؤثرة، وبدأنا بجني ثمارها وملاحظة آثارها الإيجابية على صحة الفرد في بلادنا المملكة العربية السعودية. احتضنته والتزمت به التجمعات الصحية، وامتد أبعد من ذلك لتتلقفه أيادي وقلوب وعقول وأرواح مقدمي الخدمات الصحية في المنظومة الصحية من الجهات الأخرى. وسعداء جدا بأن نجد مقدمي الخدمات في القطاع العام جنبا إلى جنب مع القطاع الخاص مع التزامات التجمعات الصحية يساهمون ويبادرون بتبني بعض أنظمته ومساراته، ولديهم تطلعات لتبنيه وتطبيقه بالكامل. وسوف يكون لنا في هذا الملتقى اطلاع ومشاهدة ومعاينة وتبادل خبرات لما تم داخل المملكة العربية السعودية في التجمعات وفي هذه الجهات المقدمة، والجهات أيضا والمنظومات من هيئات ومراكز ولجان في مختلف مكونات المنظومة الصحية المساهمة بفعالية في تطبيق النموذج، وكذلك للخبرات الدولية وأبرز الممارسات النوعية والتقنيات الصاعدة التي يمكن أن نستفيد منها وأن نتبناها وأن نجعلها موضع التنفيذ بشكل فعال. ما يميزنا بحمد الله في المملكة العربية السعودية وفي المنظومة الصحية بأننا لا نسعى للاطلاع أو تبادل المعلومة أو التجربة للأفضل، وإنما نتبناه ونطبقه ونجعله فاعل بأفضل نموذج يسعى الآخرون ليحتذوا به وينهلوا منه ويتعلموا منه وينظروا كيف تم تفعيله وتبنيه بشكل مميز وصل إلى المستفيد واستفاد منه وأثر في حياته وصحته. نموذج الرعاية الصحية الحديث تغيير كامل لمفهوم وأسلوب ونمط تقديمنا للرعاية الصحية. كما نقول للفرد في المجتمع نريد أن تغير من نمطك وسلوكياتك الحياتية لتكون مسؤولا عن صحتك وتحافظ عليها، نحن كذلك مسؤولين عن تغيير نمط وأسلوب تقديمنا للرعاية الصحية ليواكب ذلك، فتكون الصحة أولا، ونكتشف أي إشكالية فيها بشكل مبكر جدا ونتدخل ونجعل الوصول للخدمات الصحية سهل وميسر وسريع وبجودة عالية وفاعلة. وكذلك نجعل من هذه الخدمة في شمولية ومتناغمة ومقترنة ببعضها بشكل سليم وشكل مستمر وشكل مستدام، وأن لا يكون فيها أي خلل يؤدي إلى انقطاع أو عدم تكامل للرعاية الصحية. الذين يعملون اليوم في كل مناطق المملكة في التجمعات وغيرها من مكونات الرعاية الصحية والمنظومة الصحية، من معنا في النموذج لا ينظرون للتشخيص بأنه ورقة أو مخطط على شاشة أو نقاط وعينات وقطرات لسائل أو دم، ولا ينظرون لجهاز عليه أرقام بأنها أرقام فقط، ولا لملف المريض بأنه عبارة عن صفحات وأوراق وكلمات. ينظرون لها معنا في هذا النموذج بأنها أجزاء من حياة إنسان نطمح بأنها تكون أكثر رفاهية وأكثر صحة وأكثر عافية وأكثر حيوية، لأننا كلنا مسؤولون عن أن نتجه باتجاه تحقيق هذه الرؤية. عازمون وواثقون ومنفذون وممكنون، ونستطيع بإذن الله أن نحقق كل شيء. عيننا في 2025 على سنة من السنوات المهمة بعد مرور قرابة ثلثي خطواتنا نحو 2030، وعازمون أن ننتقل منها إلى تحقيق أهدافنا بشكل سريع. ما حققناه نسعى أن نرتفع أعلى منه، وما هو أمامنا وقريب سنقطفه بسرعة ونجني ثماره بشكل أسرع، وسنصل بعون الله إلى 2030 محققين للأهداف وأعلى. وأيضا لنا عين أخرى تتطلع إلى أبعد من ذلك، إلى 2040 وما وراء ذلك. طموحنا لا يقف، تطلعاتنا لا تقف، قيادتنا ملهمة وممكنة لنا بكل شيء، فلذلك ليس أمامنا أي عذر بكل هذه الطاقة وبكل هذه القوة إلا أن نقول لكل مستحيل أنت غير موجود في قاموسنا. موفقين، أتمنى لكم التوفيق وأيام بإذن الله مليئة بالعلم النافع، وأتمنى أن تجدوها أيضا ماتعة في الرياض الجميلة في هذا الموسم الجميل. وغدا إن شاء الله مستمر البرنامج، وفي اليوم والغد ستجدون كثير من الأمور التي نأمل أنكم تأخذونها وتضيفون عليها وتتحول إلى في يومياتنا وأعمالنا إلى ما يجد نفعه بإذن الله كافة أفراد مجتمعنا وأوسع من ذلك. موفقين، والسلام عليكم ورحمة الله وبركاته.
شكرا لكم دكتور محمد عبد العالي، ولا زلنا طماعين بوجودك معنا في المسرح. لم نمل حديثك وتواجدك وتشريفك لمسرحنا لبدء فقرة التكريم، وفعلا كما قال كلمة مستحيل لا تعرفها قواميسنا الصحية. حضورنا الكريم، سنبدأ الآن بالتكريم، وفي هذه اللحظات بتشريف أيضا الدكتور محمد العبد العالي تكريم اللجنة التنظيمية لهذا الملتقى. شكرا للجنة التنظيمية لملتقى نموذج الرعاية الصحية لعام 2025 على عطائهم وعلى جهدهم طوال أشهر ماضية لأن نعيش هذه الأيام وهذا المخرج المشرف الصحي السعودي. يتفضل أعضاء اللجنة التنظيمية بهذه اللحظات لأخذ صورة جماعية. لحظة ستظل خالدة بكل تأكيد في ملتقى هذا العام بجهود اللجنة التنظيمية التي عملت وقدمت وساهمت خلال أشهر ماضية لأن نعيش هذه اللحظة وأن نعيش أيضاً اليوم الأول لملتقى نموذج الرعاية الصحية الحديث 2025. شكراً الدكتور نوفل الجريان، شكراً لكل أعضاء اللجنة المتواجدين على مسرحنا. التكريم أيضاً للجنة العلمية في ملتقى نموذج الرعاية الصحية. ويتفضل في هذه اللحظات أعضاء اللجنة لأخذ صورة تذكارية على مسرح هذا الملتقى. إذن اللجنة العلمية برئيس اللجنة الدكتورة ريم البنيان، وكذلك أعضاء اللجنة الحاضرين معنا على مسرح ملتقى نموذج الرعاية الصحية لعام 2025، والذين بكل تأكيد حضروا لنا برنامجاً علمياً سينطلق بعد نهاية هذا التكريم بالعديد من الجلسات الحوارية العديدة. شكراً لعطائكم، شكراً لأثركم، وشكراً لإنجازكم في هذه اللحظة التاريخية بكل تأكيد. أيضاً نستمر في التكريم ونكرم اللجنة الإعلامية. يتفضل رئيس اللجنة وكذلك أعضاء اللجنة الكرام على مسرحنا لالتقاط صورة تذكارية بهذه المناسبة. اللجنة الإعلامية التي حضرت وعملت طوال الفترة الماضية ولا زالت أيضاً تقدم الكثير في بداية هذا الملتقى. شكراً للمهندس أنس الحميد، وشكراً لأعضاء اللجنة الكرام، شكراً لعطائهم وجهدهم في ملتقى نموذج الرعاية الصحية الحديث 2025. شكراً لعطائكم وشكراً لجهدكم طوال الفترة الماضية وأيضاً اللاحقة. أيضاً سنستمر في التكريم ولجنة التقييم والجوائز. يتفضل رئيس لجنة التقييم والجوائز ويتفضل أعضاء اللجنة بهذه اللحظات لأخذ صورة تذكارية على مسرح ملتقى نموذج الرعاية الصحية الحديث 2025. لجنة التقييم والجوائز التي تحمل على عاتقها حملاً كبيراً في مسألة تحديد الفائزين خلال الجوائز المتواجدة معنا في هذا الملتقى لهذا العام. شكراً لعطائكم. من تكريم اللجان إلى تكريم شركاء النجاح، رحبوا معي بشركة نبكو. يلتحق إذن بهذه اللحظات الرئيس التنفيذي لشركة الصحة القابضة بأخذ صورة تذكارية مع شركاء النجاح الذين ساهموا في إخراج هذا المخرج المشرف. رحبوا معي أيضا بشركة PwC. شركاء النجاح الذين قدموا وعملوا وساهموا لإخراج هذا المخرج الصحي السعودي بهذه الصورة المشرفة لعام 2025. أيضاً التكريم لشركة مواردكم. شركة مواردكم إحدى شركاء النجاح بهذه النسخة الذين قدموا وساهموا أيضاً بإخراج هذا المخرج الصحي السعودي الدولي بهذه الصورة المشرفة. شكراً لعطائكم، شكراً لبصمتكم في ملتقى هذا العام. أيضاً شريك النجاح شركة تمر. شكراً لعطائكم وشكراً لإنجازكم وأيضاً الشكر لبصمتكم في ملتقى هذا العام. شكراً لسعادتكم، شكراً جزيلاً لرعايتكم وتواجدكم أيضاً بالنيابة عن معالي وزير الصحة الأستاذ فهد بن عبد الرحمن الجلاجل. حضورنا الكريم، الشكر أيضاً لكم أنتم على هذا التواجد العظيم، ولا زلنا مستمرون معكم في يوم سيكون مليء بالكثير من البرنامج العلمي، كثير من الجلسات الحوارية، والعديد من الخبراء الدوليين والخبراء المحليين المتخصصون في أفضل الممارسات الصحية حول العالم. سنبقى وإياكم، ولكن سأترك الصوت والصورة والمسرح لزميلي الدكتور طارق السلام الذي سيقود دفة البرنامج العلمي لهذا اليوم. الله يحييكم.
أصحاب السعادة, distinguished speakers, esteemed guests, ladies and gentlemen, Assalamu alaikum and good morning. It is a great honor to welcome you to the Model of Care Forum. Over the next 2 days, we will engage in enriching discussions, thought-provoking conversations that are aimed at shaping systems to elevate health and wellness. As you may already know and will see, this forum brings together renowned healthcare leaders both nationally and internationally to share their expertise and vision. As we begin, it is important to recognize that the concept of the model of care is not a universal blueprint. Rather, its creation and implementation is deeply influenced by the unique needs of a nation's population, its available resources, its cultural fabric, and its strategic priorities. Here in Saudi Arabia, we are blessed and privileged to have the vision, resources, capabilities, and determination to redefine the healthcare landscape in alignment with national goals. To set the stage for this forum, we will begin by taking a deep dive into Saudi Arabia's unique, extraordinary journey in the transformation of the model of care. And who better to do this than the current director of the model of care at the Ministry of Health. Please join me in welcoming Professor Nawfal Al-Jrayyan.
السلام عليكم. صباح الخير. أنا آسف كنت أجهز شعري عشان أطلع على الستيج. يمكن بعضكم حضر حديث لي سابق، يمكن بعضكم ما حضر. أنا بالعادة ما أعرف أطلع أتكلم بجدية تامة. يمكن الموضوع جاد ومهم والأكيد أن أثره واضح، لكن إذا ما تكلمنا بطريقة مريحة ما راح نستطيع إيصال المعلومة بطريقة جيدة. وبعدين ظلموني، حطوني بعد الدكتور محمد عبد العالي بأسلوبه وبإلقائه، وبعدين حطوني بعد الدكتور طارق السلامة للغته الإنجليزية ممتازة، فلا عربي ولا إنجليزي بطلع ناجح قدامكم اليوم، فعاد تحملوني. I'm very sorry for the non-Arabic speakers. I was making jokes. As a physician, I was taught to speak English professionally, but my sense of humor in English is terrible, so I have to make my jokes in Arabic and then come back to you to be serious in English. In 2016, when I first heard about the model of care, if you all remember the application Trello, His Excellency Dr. Tawfiq al-Rabi'a, the Vice Minister, the Deputy Ministers were all in a group with everyone from the healthcare, physicians, nurses, students, pharmacists, and so on. I was amazed by having a minister and all the leadership in the healthcare system and groups discussing model of care, talking about how we should deliver care, how care should be done properly, what should we do right, what should we change. It's truly amazing when you see leadership going down to the people and listening. That was the first time I ever heard about model of care, and probably one of the reasons why I came to the Ministry of Health. What if I told you in less than a decade, we'll be able to change the story of healthcare in the kingdom? The truth is, this is not a rhetorical question or an idea. This is happening now and happening today. We do feel the change. The change has happened, and we're observing it now. And this is evidence of what has happened. This forum had more than 17,000 applicants to attend within a week. This tells you how important it is to the leadership, to healthcare professionals, how much they care about their communities, and how much we care about the model of care. Today, we're not gathered here as professionals only and decision makers. We're gathered here as visionaries, as change makers, and as pioneers of a cause that goes beyond systems and numbers. Dr. Muhammad talked about a lot in his speech that we're not here talking about numbers only. We're talking about value. Nearly 10 years ago, there was a bold vision that took root. A vision that to create a healthcare system where every patient feels heard, seen, and cared for. A vision that demanded that we change totally the way we think. Anything we had learned before had to change. We had to act decisively and boldly and to build a model of care that will change the standards forever. Since 2016, the center of government laid the foundation. The Ministry of Health, the health holding company, and their partners worked decisively and continuously to transform healthcare. And we see this thriving reality today. But numbers don't tell the full story. It's about the lives behind these numbers. Every time we see a number, we don't remember that there's something behind that. So, as an example, in breast care, we were able to screen 230,000 females last year. In colon cancer, we were able to screen 240,000 people last year. How many lives have been changed due to that intervention? Due to the dedication of the professionals, the people on the ground, changing lives and making stories every day. In stroke, we were able to put people back into their life by decreasing the time from 30 minutes to 26 minutes, from door to CT scan. In heart attacks, 71% of patients received time-critical treatment within 30 minutes. And that was a 42% improvement from last year. These are not numbers. These are real people, and these are real stories, and these are real lives changed. In 2024, we were honored to serve more than 20 million people. We've built on the momentum that started before us. We improved access, we accelerated response times, and we delivered care that saved lives, and most importantly, restored hope. The truth is, are we done? Have we achieved everything we want? We've done so much, but I think we're just in the beginning. The model of care has just started. We've just started what we want to do. And the road ahead is not just about numbers. It's about value. It's about impact. It's ensuring that every person, every family, and every community feels the difference. So if people don't feel the difference, that means that we haven't delivered the message we want to deliver. I ask you to look around the room. So I ask you to look around the room, to try to look around the room. So I ask you to look around the room. The innovation, the leadership, the power, and the decisions we need are here. Nothing beyond here will make a difference as much as we have within the hall of this room. So let's not just talk about change, let's ignite it. Let's make this forum about discussion, going forward, expanding what we want to do, measuring more important outcomes, and looking at impact. And just to say that this is not about healthcare. We keep on saying that it's healthcare, it's life care. And if one person feels left behind, that means that we haven't delivered our message. Thank you very much.
Thank you, Professor Naufal. It truly is remarkable to see how much progress has been made in such a short span of time, which does reflect the clear commitment in advancing healthcare delivery in alignment with Vision 2030. But while Saudi Arabia's journey is unique and deeply rooted in its local needs and culture, it is part of a larger global movement toward transforming models of care. Around the world, healthcare systems are facing similar challenges: rising demand, the need for sustainability, and the push for better outcomes through innovation. Each country brings its own solutions shaped by their unique resources, population, and priorities. Our next segment, excuse me, our next segment will broaden the lens, offering an international perspective on transforming models of care. We'll explore how various solutions are driving the transformation of care models. This perspective can inspire us to think globally while acting locally, integrating these insights into our transformative efforts. To guide us through this, we are fortunate to have our next speaker, who is the current healthcare practice president at Red Cell, who previously served as the National Director of Transformation at NHS England, and before that was the CEO of the Mass General Physicians Organization and Senior VP for Population Health at Mass General Brigham. Please join me in welcoming Professor Tim Ferriss.
Thank you very much for that kind introduction. I am really honored to be here today. I want to thank the esteemed leaders for the invitation, and I want to express my profound, I guess, companionship with all of you who are facing the very daunting task of transforming the delivery of healthcare. I'm going to start by painting a picture of the problem before us and then lead into how various countries and healthcare leaders have been approaching that problem. But I want to start by making a comment about the models of care. The 6 pillars in the models of care, I think, are exactly right. I think the models of care manifesto, if I can call it that, is it's focusing on patients, and very importantly, it's focusing on providers. I think previously the goals of care often have missed out the role of providers and the challenges that they face. The care delivery models and the transformation of care delivery models really is about changes in the work of the providers of care. And that is very, very difficult. You may not know this, but Michael Crichton, the famous author, was a student at Harvard Medical School when he wrote his first book. And his first book is the only book he wrote that was not a bestseller. It was called 5 Patients. And he followed 5 patients at Mass General Hospital. And he noticed something. This was 1968. He noticed something. He said, healthcare is changing at an extraordinarily fast pace. Very difficult for the people who work in healthcare to keep up. And then he said, in the frontispiece of his book, he wrote, the only people who can change healthcare are the people who are providing care, because it is their work, literally their work, how they spend their day, that changes. This is tough. Most of us don't sign up for a career in which we go to work every day and the rug has been pulled out from underneath us. That's the challenge that healthcare around the world is facing, because we do need to pull the rug out from under the providers. Actually, the way we're delivering care currently is unsustainable. Now, I'm going to make that argument to you now. Let's see if I can. Thank you. I'm looking in the wrong direction. Okay. All right. Did I go too far? Yes, I went too far. All right. One slide. So I won't dwell on this, but we talk about the demographic wave, the aging of the population, the increase in chronic illness. Everyone knows about this. Everyone knows that's the source of the problem. In fact, it's even worse than we are predicting. I shouldn't say worse. I should say it's more difficult. And it's more difficult because the rate of change of scientific discovery in healthcare is accelerating. Now, of course, that's a good thing. Of course, what that means is we have more curative therapies, we have more diagnostic tests. But as we add curative therapies and diagnostic tests, we have essentially the same infrastructure. I use the word chassis. We have the same chassis on which we're adding all of these new things. Actually, the number of physicians per population in the world hasn't changed much in 40 years, okay? And yet we just keep adding more things for them to do. Yes, it's chronic illness, but yes, it's new therapies. And I'll give you one very specific example. So very recently, the FDA approved new therapy for sickle cell disease. It is now possible to completely, I'll use the word cure, sickle cell disease. But the infrastructure required for every patient to receive that therapy is effectively like a bone marrow transplant. That is incredibly resource intensive. And so what happens? What happens is our physicians and our nurses follow that path and want to be part of that amazing new therapy. And that means fewer and fewer people are doing the day-to-day work of integrating care, the day-to-day work of providing comprehensive care to the populations of patients. So as we develop these fantastic new therapies, we are also redistributing the people in healthcare that are available to deliver healthcare. And that is working against us. That is working to diminish the workforce that's available to just deliver what I will call usual care instead of the advanced care. Now, as the demand is growing and the more treatable conditions we have, delivery can't keep up. And I like the word confiscatory. It's a big word. It's not a commonly used word. But when healthcare grows faster than inflation, that means it is pulling resources away from other parts, other important social goods that government needs to spend money on. That is okay, fine, for a little while. But when you do that for 30 years, healthcare has been confiscatory. And that is causing big other social problems because of all the money that's going into healthcare. So these are all good things. We're curing disease, better diagnostic tests. And for decades now, I used, sorry for the abbreviation, I used the abbreviation HIT, Health Information Technology. So health information technology has been held up for decades as the solution to this problem. It hasn't delivered. Health information technology has been very good for patient care because it means that all the people providing care for an individual are on the same page, literally on the same page. All the information that you need about a patient is now available to you 24/7. And I'll just say, having started my work as a doctor on paper and then moved to electronic patient records, there is no question patient care is much, much better with electronic patient records. But what did that do to providers? It turned me from a doctor into a data entry clerk. Okay? I had to spend hours and hours after work at home writing notes on my patients. I'm not a fast typist. I honestly, typing was never an aspiration of mine. So health information technology has been great for patient care, but it has been extremely burdensome for the professionals that are delivering care. We've got to fix that. And the good news is that there is a fix. So healthcare needs a new chassis. We can't sustain the delivery of healthcare the way we're delivering it now. What I'm writing up here is entirely consistent with the models of care framework, but I'm looking at it through a different lens. I'm looking at it through what I would call a cross-cutting lens, a lens that cuts across all the pillars of the models of care. And it really comes down to two things: technology and the jobs that we are doing as provider. Okay? So on the technology, we have to select technology more carefully than we have in the past. The technology we've selected has been burdensome to providers of care. We need to switch that model and start selecting technology, investing in technology that reduces the burden on providers. And that is here, that has already arrived. That is, I'll get into it in a minute, but you may already have heard about ambient documentation. So an AI, large language model driven method for eliminating the need for doctors and nurses to write notes. All they do is they do their work, and the computer does all the documentation for them. I have used these, and they are spectacularly effective, dramatically reducing my work. And honestly, I'll tell you a little story. When I asked my nurse about my new notes that were generated by computers, and she said, I said, you know, are these helpful to you, my notes that generated by the computer? And she said to me, you know, do you mean the fact that I now know what you said to your patient rather than before when your documentation was, let's say, spotty? So the computers don't leave things out. They don't miss things. This is an extraordinary advance, and it's just one of the advances. So the most important thing that I want to stress, though, is when we select that technology, we have to work on expanding access. Because as the new technologies come for therapies and diagnostics, as the demographic wave of chronic illness rolls against the providers of care, our big problem is going to be access to care, because we are overwhelmed with the demand. We have got to make sure that we are providing access to patients, and so we have to select technology that's going to help us do that. Now, the new and redefined roles, so the first thing is, from the patient perspective, it's going to be much more self-service. Okay, so we're all used to using our phone, using smartphones for serving our own needs, and it's gotten better over time. Healthcare is entering that space, and will be. It will take a while. At first, the apps won't be terrific, but they will get better, and they will get better quickly. So I'll say, if you haven't done it yet, there's a website called Open Evidence. It is a collaboration between MIT and Harvard. And you can go to their website now and type in a question, a medical question, and the answer that it gives you is astoundingly accurate. Okay? This is basically an encyclopedia of all medical knowledge that is now available free to the public to answer any medical question. I've used it dozens of times. I have not found a single mistake, okay, in the most complicated questions. That is a huge democratization of the expertise of physicians, and will be, that and many other apps like it, will be transformative. There will also be increased responsibility of non-physician team members. So this is that tired expression now, it's cliched, everyone practices at the top of their license. Well, practicing at the top of your license in a world where medical knowledge is at everyone's fingertips really changes how we think about models of care. It allows us to think Do we need a doctor in that role? Can it be a nurse practitioner? Can it be an allied health professional? Can it be a community health worker? All right, we can think really radically different when we think about the technology combined with teams of care that are organized around the principle of practicing at the top of your license. That has big educational implications, because how I trained as a doctor is not the way we're going to be delivering care in the future. And that means we've got to train people really differently. We have to train people for the world in front of them. So let's get to the, what this journey looks like. So patients will be increasingly driving their own journeys. And I want to make a comment here, because a lot of people get worried about what's called the digital divide. So what if you're not capable yourself of driving your own journey? Well, if the people that are capable have used automated processes, there will be more providers available for those who aren't capable. So this is what I mean by access. In fact, the technology will serve the people who can use the technology and leave humans, professionals, more available to serve those who can't. This is very good news for the disabled. This is very good news for the underserved. There will be more professional availability to serve their needs if the self-serve people can use the technology. The second point in the journey, caregivers will be empowered by technology tools. The computer-based assistance, this website that I just spoke of called Open Evidence. Chatbots as gatekeepers. So primary care has been the gatekeeper. Like, you need primary care to get your referral to the specialist. You need your primary care to get referral to the radiologist. I see Giles Boland in the audience here. So that is going to go away. It's going to go away really soon. It is now unnecessary to go to your doctor to get a referral to go to another doctor. Let's just go to that other doctor. Well, patients don't know what that other doctor is, but the computer does, okay? This has already started, so I wanted to just say in England, there are now pharmacy direct services where for a limited number, right now it's starting with 12 conditions, but 12 conditions, you can go directly to a pharmacist, and the pharmacist will provide you with the treatment, the diagnostic tests and treatment. That is just the beginning. Okay, that is just the beginning. So all physiologic measurements will be automated. So if the information can be read by a computer, then a computer can do a better job of it than a human can. And I know what I'm saying is very controversial. I was told to be provocative, so I'm being a little provocative. But let me just tell you that the EU just gave a CE mark to its first completely automated dermatology diagnostic tool. And that tool, it's called Skin Analytics, basically allows a AI engine to look at photographs of your skin and diagnose with greater than 98% accuracy whether or not you have skin cancer. Okay? Now, what's interesting is about that is, well, and I hope I'm not offending dermatologists in the audience when I say this, but what's interesting about that was until very recently, we didn't know what the accuracy of dermatologists generally was. But a paper was published in the Journal of the American Medical Association a few months back that actually showed that dermatologists in general get it right in the high 80s. Okay, so high 80s by people, high 90s with an AI computer-driven. I don't know about you. I'm sure the best dermatologists do better, but I think I would like to have the AI engine look at my skin. I do have type 4 skin, by the way, which means I'm very prone to skin cancer. And then the overhead, so the back office functions. This is actually going to be the starting place for AI in healthcare because it doesn't involve regulatory oversight. So you can put AI engines into your finance, we've got Jackie Rock here, we've got the commercial contracts. I'll say the CEO of the largest sovereign wealth fund in the world, the Norwegian sovereign wealth fund, has said overhead rates in administrative processes should drop 50% as a result of AI. That is a staggering amount of reduction, 50%, okay? And I've seen this is starting to happen quite quickly because of you don't need regulatory approval, unlike the clinical systems. So I'm going to go very quickly now and just say that in the categories that I think about, the technology will advance in healthcare, the provision of healthcare, in 4 categories. Clinically specific. Clinical applies across the board to clinical. Administrative, and then metrics and measurement. I'm just going to give a couple of examples. So I'll use, well, I just have to say that the digital ITU rounding, I have to mention this. I was here 3 years ago and had the extraordinary pleasure of seeing the virtual hospital that Saudi Arabia has set up. And the rounding system for rounding on neonatal, so babies in the neonatal intensive care units, and the dramatic drop in mortality at community hospitals because they had an expert from a Riyadh hospital rounding virtually with the team. I mention that in every speech that I am honored to be asked to give because I have not seen anywhere else in the world such a dramatic application of technology for the health of the public. So I was asked to come here to bring an international perspective, but I want you to know I am also taking what I observe here as extremely advanced and taking it around the world because I can tell you the world can learn a lot from what you're doing here. So let me just say another word about how technology and AI can advance. So in much of the world, there are very few pediatric neurologists. And pediatric neurologists are the people that diagnose autism. Autism is rising significantly. It's difficult to diagnose. And so it turns out that most parents wait up to 2 years to see whether or not the child that they have concerns with is able to see a specialist to diagnose that problem. Well, it turns out there's a company that a parent can take 2 3-minute videos of their child in the home, and an AI engine can diagnose with greater than 95% accuracy whether or not that child has autism. Why are we waiting 2 years to see a pediatric neurologist when we can accurately triage in a couple of minutes automatically? Okay, these are I've just mentioned a couple of examples. There are many more. I won't go into them, but this is very exciting space. But I want you to understand that this is narrow. It is in one specialty, all right? It will take many, many of these across all specialties to add up to be a significant shift in efficiency. But that process is starting, and we should all be working on that process. The second is clinical cross-cutting. I already mentioned open evidence. This is dramatically different. I have seen the large language models in use in this area. Care navigation, getting you directly to diagnostic. Why do you need to go to a doctor to order the diagnostic test if it's perfectly obvious that you need to go? Perfectly obvious to a generative AI engine that is programmed to deliver that. And then screening for social determinants of health is yet another example of how AI engines can help us be more efficient in collecting this data. I've also already mentioned the administrative, ambient documentation, the HR, human resources and customer relationship management software. Big jumps in AI in that space, very important to healthcare. The AI-based finance and procurement software, and then coding. Coding, it's all clinicians are looking forward to the day, which is not very far away, when they no longer have to code in order to generate the bills for their work. That is coming soon. And one of the things, this is not very, most people don't like to talk about metrics and measurement. It's sort of boring. Can I just say that because it's so difficult to measure accurately the delivery of healthcare, we actually don't measure the right things. We need to measure outcomes much better than we do, and we need to measure unit cost. We need to measure how much it costs. Every other industry measures unit cost. In fact, they do their accounting in unit cost. Healthcare doesn't. Why doesn't healthcare use unit cost? Because it's too difficult to measure. Well, that is yet another thing, that it is not hard to measure with AI engines. So I'm excited about the fact that very soon we will start actually measuring what we need to measure in order to determine how efficient we are. So that's another big one. How will this happen? So very quickly, it's not going to be easy. You all know that, but it's not going to be easy. There's the usual challenges with innovation, adoption, regulatory issues. I use this term guild protectionism. Guild protectionism. Giles doesn't know anything about guild protectionism. The radiologists are, as a field, are facing an existential moment. Technology to reduce overhead from business function will be the first because it's not regulated. Building conviction around clinical technology, we've got to build examples of how we do it so that other people can develop confidence. Because if you don't have confidence, you're going to resist the change, right? So building examples. And then the financial incentives will speed the uptake. Yes, finances are important. But let me just say one thing. I think the biggest driver of change in technology in healthcare will be patients. And that is because patients who are suffering, who don't have access to healthcare, are going to go look for how to relieve their suffering any way they can. And if they find it on the internet, they're going to use that. They're going to use decision support tools that are put forward, even if they have indicators that say, oh, please don't depend on this, go to your doctor. The fact is, if you have trouble accessing healthcare, you are going to try to find relief any way you can. That's going to be the biggest pressure on the providers of healthcare is, boy, we better move quickly to adopt or the patients are going to leave us behind. So I think that's it. Yep, that's it. I want to thank you so much for this, the opportunity to speak here. I hope I have been, if nothing else, provocative. I'm deeply honored to be here. You have a big challenge in front of you. I am really excited to participate and help in any way I can. I think the journey you're about to go on over the next 5, 10 years is a fantastic journey. I'm excited for you, and thank you very much.
Thank you. Thank you, Professor Ferris, for giving us a lot to look forward to. I think I speak for most, if not everyone, when I say, how soon can we get the ambient documentation into our hospitals? Before we talk about the next session, just a public service announcement. Translations are available from Arabic to English through devices on the side, but also from English to Arabic. فأجهزة الترجمة موجودة on the side of the stage. Now, building on this global outlook, our next session is a fireside chat titled Global Innovations in Model of Care Transformation. This discussion will delve into how innovative strategies and cutting-edge technologies are enhancing integrated models of care around the world. Moderating this fireside is Ms. Jackie Rock, who is currently serving as a senior advisor to the CEO of the Health Holding Company. She is a distinguished leader with a wealth of knowledge and background driving large-scale healthcare transformations in her roles as the former Chief Commercial Officer at NHS's Test and Trace, as well as the Chief Commercial Officer to the UK's Ministry of Defence. She has more than 20 years of experience in various C-suite roles in investment banking. Joining her is Dr. Giles Boland, the current president of Brigham and Women's Hospital and executive vice president at Mass General Brigham. Dr. Boland, a renowned academic and healthcare executive, has led transformative initiatives to align healthcare delivery with emerging technologies. Together, they will share their valuable insights and continue to inspire us to think globally while acting locally. Please join me in a warm welcome, Ms. Jackie Rock and Dr. Giles Boland.
Thank you very much. And good morning, Dr. Charles Boland. We're absolutely delighted that you could join us this morning. I wonder if we could start this conversation and you can just sort of set a bit of context, a bit of an introduction to yourself, your role, and the landscape of which you're working.
Yeah, thank you, Jackie, and good morning to everyone. It's an absolute pleasure to be here. I always enjoy my visits to the Kingdom, particularly as I observe the way you're transforming healthcare. And in fact, we have as much to learn from you as you from us. I was interested by Tim Ferriss's talk, who really set me up for this, that you really are doing amazing things in this country. But a little bit about myself. Yes, I have been a radiologist in my clinical career, but I'm now a hospital leader. I'm president of the Brigham and Women's Hospital, which is a large academic teaching hospital in Boston, part of the Harvard system. I'm part of a large organization called Mass General Brigham, and we'll get into that a bit today in terms of where I would like to share some of my thinking around governance and how to drive clinical programs, quality, safety, etc. And I'm also president of the physician organization. I'm an executive at Mass General Brigham, and I've been in that system for 32 years now, originally from the UK, as you can probably tell. How's that?
Yeah, excellent, thank you. And given the journey, the model of care journey and the journey that the Kingdom is on at the moment, can you share with us a little bit of the insights on some of the challenges that you personally have faced in terms of health system integration?
Right. Now, as I said, Tim Ferriss really set the stage for this, the complexity of healthcare today. And it was interesting from the book that was mentioned in the 60s that healthcare was rapidly changing, etc. I think it was Michael Crichton he mentioned. And that's exactly what we say today. If you really think about it, healthcare is incredibly complex, and the ability to deliver that efficiently, effectively, in the best interests of patients with the highest quality and safety, the highest value, the lowest cost, etc., is incredibly difficult to do. There are a myriad of challenges in healthcare today to deliver that, and Tim touched on several of those: access and demand, the increasing age of the population, the new drugs in development, but those are just some of them. So you go from how are we going to make money in this environment, who's going to pay for it, political changes and changes in value-based care, for instance, or capitated care, moving to systems that organizations are consolidating to capitalize on their ability to provide care for larger groups of patients. The focus on efficiency and productivity to try and drive a more cost-effective care. Disruptors like the Amazons of this world entering the space. Quality and safety is ascendant. Then IT innovation, and Tim went into a lot about IT innovation, how that is disrupting care. Precision medicine. And then there's a huge impact, and I might focus in a little bit on this, on the impact on providers, and Tim touched on this too. What are all these changes making on providers and their ability to deliver care? Because frankly, we are still approaching this, in my opinion, in the old world model, and Tim's reference, and with the old chassis. And I'm going to say something myself which is a little provocative. Here's one of the existential challenges. Physicians, particularly physicians, but other providers too, know an incredible amount. They know how to care for patients, they have domain expertise, and they're very skilled at what they do. And they deliver their care to patients. The question is how they deliver that care and in what settings. And if you ask one particular physician how they do it, they will tell you. Now here's the challenge. You'll go to another organization, or sometimes the same organization, and sometimes even in the same department, and you go to the physician and say, well, how would you deliver this care? What do you think are best practices? Guess what? Not infrequently, they're going to give you a different answer. And that's the existential challenge, I think, for us in healthcare at the moment, is moving from this siloed, decision, clinically based environment where physicians are driving the care of patients, which they should, obviously, with nurses and APPs, advanced practitioners, as Tim mentioned. But how do we aggregate the talent, the best practices, such that we're all delivering common best practices? And I'll end my answer in a minute, Jackie, but I could go on. And I realized this like someone knocking me on the head. When I went from Mass General to the Brigham, we're in the same organization, two big academic medical centers, as a chair in radiology. At the Brigham, same organization, now Mass General Brigham, in radiology, everything was done differently. The MRI protocols were different. In the system, we have 12 hospitals, 12 different MRI protocols, 12 different contrast doses, 12 different report templates, 12 different ways of operating the machines, etc. This is within the same organization. And everyone was fiercely proud of what they were doing. And a light bulb went off in my head and said, this isn't right. This isn't serving patients. We want patients to navigate anywhere in the system, now it could be in the country, and be able to get the same excellent care and expect the same high standards of care. In my analogy, radiology, a patient can go anywhere in the system and get exactly the same MRI and have the same high quality reading. So I, along with others, pushed to harmonize the clinical activities within our organization. And this is where it comes to the big challenges in a way of how to do that, how to deliver that. And that comes to governance. And governance is about who's going to make the decisions, how are you going to implement a disparate, fragmented clinical delivery system into a unified, coordinated, all rowing in the same direction, all delivering the highest quality and safety standards. And it can only really be done with a single governance system, which gets back to my point, and I'll end with this, Jackie. If you ask physicians how to do it, you'll have one opinion here, you'll have another opinion there, and you'll have another opinion over there. We need those opinions. I'm not to say that we should toss them out. We actually absolutely must have those opinions, but we need to get together and figure out what is the best way to do this collectively and then implement it across the system, and that gets back to governance.
Yeah, I totally agree on the governance perspective, but again, yeah, just a little bit more insights of how you did it, because we can lay governance, we can mandate, we can set policy, but how do you bring everybody? There are so many people in the system, from the clinicians to the administrators. How do you bring them all on the journey with you?
Well, there is the rub, and there is the challenge, because everyone has an opinion, and everyone has been used to having an opinion and being able to exert their decision rights. Frankly, the reality is you have to remove some decision rights from many of the individuals. So what we have done in Mass General Brigham, we have gone, so we had two departments, I'll just make it, it's a little simplistic to say it, but essentially this is the way it has happened. We've had departments at the Brigham and we've had departments at Mass General. You could think about this as a departments in a particular hospital in Riyadh and another hospital in Riyadh. We have combined those departments with a single leader. So where there were two chiefs, let's say of Department of Medicine, there is now, well, actually not quite with medicine, that's coming in the spring. But of the 19 departments we have across the system, we now have 16 with a single leader. We're going to have, and this is happening right now, single vice chairs, single division chiefs. We now have reorganized the chief medical officers' sites. We've gone from fragmented governance to a single quality and safety governance across the system, single chief operating officer across the system, and so on. So we're right in the middle of transforming our governance to, for want of a better word, single decision makers to be able to provide nimble and efficient decision making and execution. Now, why is that a major challenge? Well, obviously, some people are losing their jobs. That's existential. And because of that, a lot of people are unhappy. And as you go through this process, well, who am I going to report to? Who is going to be my boss? Oh, it's going to be from that person from that other hospital who's coming here. I don't know them. How can I trust them? This is really hard work. It's about people, it's about their lives, it's about what they have invested in for their careers and their academic careers and their clinical careers, etc. The way to do this, which is hard, is to really work as much as you can with your people to help them be informed, in appropriate cases to help them be part of the decision making. But at the end of the day, someone has to make the decision that this is the way it's going to be. If it's too top down, then you alienate your employees. And guess what? In my organization, we have alienated the primary care providers. All our primary care doctors in the academic medical centers now want to unionize because they've lost agency and autonomy, and they don't believe that their voices are being sufficiently heard. So one has to be very careful in the way one goes about this, because you might lose the enthusiasm and buy-in from your employees, including doctors.
Yeah. How long has it taken you? I mean, you said you're still on the journey here, but what sort of the timelines are we talking?
Well, we tried it sort of half-heartedly, if you will, for about 3 years, starting in 2020 in radiology, where it started after I moved up to a different position, and I advocated strongly for there to be a single chair of radiology across the 12 hospitals. And that was the first department, and then 3 or 4 others became the same way, to have a single chair. But we left the departments separate. We had a single leader, but left the department separately. The problem if you leave the department separately, at least in our organization, is this department is still very proud of what it does and wants to hold on to everything it has, even with a single leader. And then this department also wants to hold on to it. In my world, in radiology, people would say, well, we wrote all the articles about how to image liver disease. Well, guess what? The other hospital said exactly the same. So then it becomes a bit of a fight. And even though you have a single leader, the different cultures, the different way of thinking about things just doesn't work. So in March last year, almost a year ago, we said that is not effectively working around being able to implement these best practice clinical programs. We are actually going to bring the departments together into a single department across the whole organization, such that we can now effectively, or at least that's the goal, work together, collaborate together, develop best practices together. The key here is, though, because a lot of people are struggling with this because they're losing agency, they're losing autonomy, is why are we doing this? Now, I've told you why we're doing this. You know why we're doing this. It's around patient care. It's around bringing the best practices to patients where they want to be cared for, always, every time, and everywhere in our organization. However, it's amazing how difficult it is to get that message across, particularly to physicians. They believe it, they want to believe it, but to go from a conception to reality is really hard because you're disrupting people's lives, their cultures, the way they've organized themselves, the way they've made decisions, and getting over that, I don't know, crossing the Rubicon is the appropriate metaphor, but getting over to where we really need to be all working together in the interests of patient care is actually really, really hard. It sounds easy. Everyone would say, yep, that's the right thing to do. We must give the best care to patients every time. But actually all believing it in a way that we put down our legacies, our cultures, our decision rights to some extent is very hard.
That's amazing. Thank you so much for sharing your journey, the insights. We could talk for hours.
Absolutely.
I wish we had the time, but unfortunately our time is up. So thank you very much. Please show
Thank
your
you.
appreciation to Dr. Charles Bowden. Thank you.
Thank you, Ms. Rock. Thank you, Dr. Thank you. The insights that we've just heard are great, and they do reflect challenges that likely would be faced wherever these innovations and changes are to be implemented. This is an excellent setup for the talks that are to come and the sessions to come after the break, which will go into a national perspective and leadership in this national perspective with panelists that span the ecosystem within the healthcare arena within the country. As we get into the break, there will be a QR code. Please, I ask you to answer some of these questions, which will give us some insights and help facilitate the conversations to come. The prayer area will be next to the food court or the food and networking area. With that said, please have your break, your coffee, and get ready for the next sessions to come.
السلام عليكم.
ارفع شوي.
السلام عليكم. السلام عليكم. لا 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 أبغى أصيح بيطلع الصوت يعني. قربها جنبي شوي.
قربي كيف يعني؟
يعني كذا.
هي بيجيب الصوت من بعيد.
كذا.
عشان ما يطلع الباب.
Ladies and gentlemen, we're gonna start shortly. Please be seated. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Shaping the Model of Care, a National Perspective. In this panel, you will be exchanging views about national strategies for integrated care with leaders of the healthcare agenda in Saudi Arabia. Our panelists will discuss the need for transformation, assess our movement in this direction, and suggest guiding themes such as challenges to overcome, prerequisites for success, and the importance of leadership, bringing together the national healthcare ecosystem and focus on lessons learned. Please welcome our moderator, Dr. Hussam Al-Faleh, and panelists.
Assalamu alaikum wa rahmatullah. Sabah al-khair, good morning everyone. It really gives me pleasure to be moderating this esteemed panel of distinguished experts and leaders in healthcare. And I'd like to welcome everybody to this panel that I hope would shed light on the model of care and what has happened, how should we shape it, and where are we going to go with the transformation of the model of care. So as a way of introduction, my name is Hussam Al-Faleh. I'm a physician, a cardiologist, and was part of the many teams that worked on the design of the model of care and in the healthcare transformation in MOH as a whole. So this journey started around 2016, and the focus in of the transformation of healthcare and MOH got kick-started on that time. And as a lot of you know, there were multiple components of this transformation, multiple elements, but the model of care transformation took center stage and was the first component of design at that time. So going back at the design phase of the model of care, there were what I think are 4 key aspirations. The first aspiration is to move the focus from the perspective of healthcare delivery and how we should be thinking about it, from healthcare institutions to focusing on the citizen, to the beneficiary. So the model of care aspiration, or the transformation of the model of care, took into account centrality of the citizen. That was really the key component. Instead of us thinking about how we should change services from our perspective as practitioners or as healthcare institutions, the change should actually come from the expectation of the citizen. So that was the first aspiration. The second aspiration was activating the citizen. How do we empower him to take care of his own health and care? The third aspiration was attempting to move care delivery as much as possible from the hospitals, from tertiary care centers, towards the community, towards primary health care centers. And then finally, one of the biggest aspirations is to move away from fragmented, disjoint healthcare delivery to a more integrated care delivery. Delivery that actually dissolves these barriers between these different levels of care, primary, secondary, tertiary, so care becomes seamless and navigation of care becomes easy for the citizen. So that was the design phase, and in so doing, the thought was that we needed, if we were to actually transform the model of care and design it differently, we need to think of what the needs of the populations are. And there were 6 needs, key needs for a population. You are either healthy, and the question is, how do we keep you healthy? You either have an emerging condition that requires elective care, a surgical procedure, for example. How do we take care of you? You might have chronic disease. How do we manage chronic disease? You might actually be faced with an urgent health crisis. How do we take care of you in the emergency settings? A woman is pregnant. How do we actually take her through that journey of pregnancy towards safe delivery and take care of that newborn? And then finally, everyone is going to come to an end. And some of us will have terminal disease. How do we take care of you in at these final stages? So these are the 6 systems of care that the focus was on. And in each of these systems of care, these 6, multiple interventions were developed. And so over 40 interventions were developed across these 6 systems of care. And 15 or more cross-cutting interventions were thought to be key enablers to the many other interventions in these various systems of care. So this was the journey around 2016, 2017. So with that in mind, this is really an introduction about what has happened. It was really, I just wanted to emphasize it. With that in mind, I'd like to introduce our panelists, distinguished panelists. And to my left is Major General Dr. Ali Mansour al-Barrak, who is the head of Healthcare Services Department, Ministry of Defense. Dr. Ali is a physician by background who's specialized in gastrointestinal diseases. He's also worked in infectious diseases and took on multiple roles, leadership roles. At some point, he also led the CDC, the current public health authority at the inception. Dr. Abdulaziz Al-Raj, he is also a veteran. He's an emergency physician by background. He used to be the chief medical officer until very recently, 2 months ago, I've been told by him, in King Faisal Specialist Hospital and Research Center. And now he's moved on to become the Deputy General Supervisor of General Directorate of Medical Services, Security Forces Hospital Program. Dr. Abdulaziz, as I mentioned, is an emergency physician and has assumed various leadership roles. He has interests in leadership. He has interests also in quality. And then, of course, to his left, Dr. Saleh Al-Tamimi, who is also a senior emergency physician, pediatric emergency physician, started out, like myself, in King Saud University as an assistant professor, and then moved on to various roles, leadership roles in emergency medicine. He became the CEO of King Saud Medical City at some point, and then went on to the private sector, Dr. Sulaiman Al-Habib, where he led emergency services and departments in Sulaiman Al-Habib Hospital, and then moved back to the Ministry of Health and is currently the CEO of one of the biggest clusters in Saudi Arabia, R1 cluster. And then last but not least, Dr. Umar Al-Shinqiti. Dr. Umar Al-Shinqiti is a health economist. He always says that he saw the light. He was a physician and then went into health economics, my old boss. Dr. Umar used to be an academic, and then he moved on in his capacity and his background in health policy, health economics, led the Program for Health Assurance and Purchase, also known as FAB. He's the founding CEO. I'm going to say just a very small anecdote about Dr. Umar. So when I was, so I'm an interventional cardiologist. I used to work with the model of care team. And Dr. Umar kept asking me to come and join FAB at the time. And I really didn't know how an interventional cardiologist, how would he fit in a public payer entity. And so he kept, trying to convince me. But at the end, he managed to pitch it in this way. He said that if you come to the model of, if you come to FAB, you will be an enabler of the transformation of the model of care. So I'm always going to say you had me at the word model of care. And I joined at the time, 2018, and the rest is history after that. So this is this distinguished panel, I think, have a lot to say about what has happened around the transformational model of care. And there are various areas that I'd like to address and pose to the panel. I think the first question that I wanted to mention or to address is that the journey of transformation of the model of care is really treacherous, is really daunting and challenging. And throughout and it's also not non-linear. It's not an easy area to transform. So I think that's why it's important always to bear in mind the why. Why are we even trying to do that? So the question I'd like to pose to the panel, from your perspective, is there a need to transform the model of care? Dr. Ali.
Assalamu alaikum wa rahmatullahi wa barakatuh. Yes, we need to transform.
And why?
Health delivery is not like it used to be before. I mean, when we take a journey of 60 years back, we had a lot of challenges in the kingdom to deliver care around large area, remote areas, where we had implemented a lot of preventive measures by giving vaccination, reducing the mortality for pediatric, for the maternal. We had improved the curative part of the health delivery. But we had gaps in between, and with increasing the demands of being effective and being, from economy point of view, we can't spend more on curative rather than preventive. So it was thought that preventive measures for a non-communicable disease, especially when we faced in the early 2000s the problems of obesity, the diabetes, the road traffic accidents, and other infectious outbreaks that are happening from time to time, that necessitate to look at the health system in a different way, to be agile and to be effective and to be population-based rather than patient who comes to the healthcare system. Usually in our culture, we go to the hospital or to the specialist. So transforming the ideas in the population to go from primary care and then into the system of healthcare delivery, at that time was thought to be the way to start. Putting that on the virtual care and also empowering the communities with the health education and health promotion made it more feasible to look into the dimensions of health from maternal childhood, and then making people well, and then at the end chronic disease management, and at the end of palliative care, making them all into the component of this population-based approach. Being part of the Ministry of Health, thinking at that time in 2016 until 2018 when I was in the Ministry of Health, at that time leading the non-communicable, push for empowering the population to look into their health, be aware of the food, be aware of the health aspect of all other issues that we are handling in life, transportation, making communities that are closed healthy, and also making them aware of their medical problems and their needs. So that's, in a nutshell, making that population empowered and also making sure that we are tracking them through the pathway from virtual to primary care and then to the specialized, and taking their disease or preventing their disease before it happened.
Thank you very much. So, Dr. Abdulaziz, do we need to transform the model of care, and why?
Thank you, Dr. Hussam. The answer is yes, definitely. And I think there are two main reasons for us that we need to change our model of care. The first one is sustainability, and the second one is quality. And if you're going to look at for reason why we need to change to the new model of care, I can list you many reasons, but I'm going to summarize this in the reason from the perception of four individuals. The first one is the beneficiary, the patient. The second one is the clinician who's providing the care. The third one is the healthcare organization. And the last one is the entity or the government or the payer. So from the patient perspective, the patients, they should not struggle into getting an access to healthcare. They should have a continuum of healthcare where people will look at their care as a holistic approach. And as mentioned before, from the prevention up to the end of life care and also long-term care. And that is basic right that he should have them. The clinician point of view, I'm talking about myself as an emergency physician, I met many occasions where I have been frustrated trying just to organize or arrange or coordinate care for patients or transfer for patients. And that's really exhausting for the clinician and take him from doing his main job and taking care of patients. Now this thing is much improved with a proper referral system, a proper coordination, and a proper inter-organizational communication. If you look at the organization themselves, they are no way that they will find difficulty and struggle in sustainability. And basically because of the care provided is used to be done in silos. And when you provide the care in silos, that means you have to use more resources than if you coordinate your care with other organizations where you can really be more efficient and also be more, you can actually deliver more standard of cares and etc. And for the payer now is facing challenges with all the increasing costs of healthcare. So the organization and the healthcare model completely should be changing in a way that they will be more efficient and outcome-based and value-based. So all these reasons definitely require a change in the model of care to the new model of care.
Dr. Saleh Tamimi, your thoughts. Do we need that change? What compels us to change?
I agree with what has been said. I can probably add that it was not a choice but a necessity for two main reasons in my mind. Number one, that for almost 10 years, just before the model of care started, the life expectancy of Saudis remained at 75 for almost 10 years. Number two, the cost of care was growing at 7% annually, which is double almost Europe. For those are, in my mind, probably the biggest reasons why I think it is a necessity. We've built an inverted pyramid of healthcare, focusing on acute care, tertiary care, and that led to very expensive care until 2016. Saudi citizens did not have a designated family physician. And so they actually had no primary care or preventative care. And I thought that was not appropriate, honestly. So yes, of course, it was a necessity. And I'm glad we did it. And today, I think we are way better than 6 years ago. Thank you.
Dr. Umar, your take on this, and I just want to remind you, Dr. Umar is the advisor to His Excellency the Minister. I forgot to mention that. Dr. Umar, from your perspective, why is there a need to change?
Well, I agree with all what the reputable colleagues have mentioned. I would just add that the moment in our historical transition within the Kingdom, as Dr. Saleh was saying, necessitated that. So we went through a demographic transition over the past 20, 30 years. With that, we also went through an epidemiological transition, going from acute disease into chronic disease. And we went through this very quickly. In a very short, maybe 2 decades or so, the burden of chronic disease became significant compared to acute disease. And the model for caring for chronic disease is completely different than the model of caring for acute disease. Our hospitals, our clinics, traditional medical practice is geared toward acute care as opposed to chronic disease management. So we needed a revolution to be able to actually respond to that challenge. It's a significant challenge. We've looked at the other countries, we've looked at the trajectories of many other healthcare systems and the challenges they face because they didn't tackle their problems in a timely fashion. At the same time, I think, so this is from the challenge side. At the same time, I think the opportunity was too big to miss in a way. I think the Vision 2030 and the ambition that came with it, and the agility and the boldness and courage to take the next step and to move in the right direction and to break all the barriers and the challenges and dream to do something that others were not able to do, made it clear to us that this is a problem for us to tackle. Now, if you talk to many healthcare experts around the world, they will tell you that in order to be able to manage this chronic disease epidemic, you need to do 1, 2, 3, 4, 5. I think there is a convergence of insight across the globe around what needs to be done and what with this new model of care needs to be. I think the challenge across the board in many countries is either the lack of willingness to take risk and to invest political capital to do this, or lack of capabilities. I think for us, we have both. We have the political will, the support, the passion to move forward, all the way to the top of the leadership decision-making process. And we have capabilities and resources. So if any country would actually meet that challenge, inshallah, it will be Saudi. So that's another way of looking at this.
Thank you very much. So the why is very clear. One of the things that intrigued me in one of the talks this morning, one of the international speakers talked about the fact that when you talk about change in care and how it should be done, and if you ask 3 or 4 physicians, they're going to give you different perspective of how change is. And so with that in mind, if we talk about transformation of the model of care, what does that look like? What does success look like? When do we say that we have managed to transform? Dr. Ali.
First of all, we had to understand what's the transformation, what's in it for the community, what's in it for the health system itself. So that these physicians and not physicians alone, all the healthcare sector who are providing these, different levels of care, understand what's in it for them, what's in it for the population that they are serving. Keeping in mind that the transparency of the changes that are happening had to be what do you call it, a clear, focused points for the patient themselves. In our health system, we are privileged that we have a lot of expats that are helping us to deliver the care. We have our own people, Saudis, who are being trained at different parts of the world. They need to be all aligned into these goals and also keep on reinforcing these model of care and these factors that they would need to achieve to deliver it to their population. Having all of this into a governance of a group of hospitals, primary care, and also being aligned with the Ministry of Health as a governance for the all health aspect, and to the government where health policies are in each rules. I think we could reach to that. We are at the road, but we are not yet at the end.
Thank you. Dr. Abdulaziz, what's the litmus test? How do you know that all the efforts that are done have actually managed to transform the care in the way we aspire to? What does success look like?
So let me answer you clearly. It's the outcome. So I think the outcome of the care provided is the one which is measuring the success of the model of care. And going backward, what I wish that, or I envision the model of care, how it's going to be, or how it should be, I would say in a few years, we hope that to see a completely patient-centric model of care, where it's all about the patient, even the clinical pathways, even the journey of the patient, it's all about the patient. Now we have a problem that most of the organization, they're organization-centric or even resource-centric, which is a problem. And this needs to be shifted to a more of patient-centric care. Again, the patient, they have the right to have a full access to medical care anywhere in the country and at any time.
So when you say outcomes to gauge success, what are you referring to? What kind of outcomes?
So when I say outcome, it includes all the outcome for the possible chronic diseases, for the screening that we've done, even for the acute illnesses, all the prevention that's being done, all the communicable, non-communicable disease, all these, what I mean about outcome. And when I say outcome, that outcome should be at a high standard, high quality, and improve mortality and morbidity of the patients. At the end of the day, this outcome should be linked with the value, because the patient came to the organization looking for a problem that the outcome should address, and that basically is the value-based care that need to be also adapted.
So, Dr. Saleh, Dr. Abdulaziz is talking about value-based healthcare as a means for gauging whether transformation happened. How do you look at that? How do you look at success of the model of care transformation?
I think it's important that we look at objective outcomes. And I would choose one primary outcome of interest is life expectancy of Saudis. So if we start seeing life expectancy, the needle moving up, and we reach our objective of 80 years by 2030, then the model of care and all the transformation has worked. If we don't, then we're not yet there. So this means that we have to be honest with ourselves and measure secondary outcomes of interest that are patient-reported, that are very objective, like prevalence of obesity, incidence of diabetes, of hypertension, incidence of Saudis going on renal dialysis. All these secondary outcomes of interest that has to be tangible. The rest, there is a slew of process metrics, but these process metrics cannot tell us. They can tell us that we are doing or applying best practice, but they cannot tell us that we have achieved much. Thank you.
Dr. Omar, what's your perspective around success? And you, I mean, through the work that you've done in the program for health assurance and the build-up of the public payer, the banner that you always use is value-based healthcare is where we want to go. And so when you look at the model of care and you, from that perspective, how do you say, when would you say that we've actually gotten to the target that we want?
So I think model of care is the engine that leads to value-based healthcare at the end. So this is the how that the system should be supporting to be able to achieve value-based healthcare. I think, in my view, a combination of an assessment of the outcome/impact of care that could be at a process level or a disease level or a population level, or impact in terms of mortality or disease burden, disability, adjusted life years, etc. on one side, plus a metric for resource utilization on the other side, be it unit cost, be it how much we're spending on healthcare per capita, GDP basis. And in addition to these two, a continuous improvement in these metrics. It needs to be continuously improving. I think that's a fundamental component of a resilient, future-proof model of care. It needs to be continuously improving. We're dealing with a complex adaptive system. People's preferences change, people's needs change, environmental factors change, lots of things, technology changes. And we need to be adaptive and agile and transform as we go. So transformation is not a one-time thing, it's a continuous journey, it's an improvement. So any metric that we impose needs to show this continuous improvement, needs to show this learning as we go forward. Again, so it's a combination of impact on health outcomes and impact on resource utilization in a continuously improving fashion.
So when it comes to leaders and it comes to practitioner, first line or physicians, for example, nurses, it's not only about the outcomes of patients, which is really of prime importance, but it's also how much resources are we putting into these delivery of these outcomes. And as was mentioned by Dr. Abdulaziz, it's also about sustainability. Are we able to actually move this forward and continue to deliver good value, good quality of care? Dr. Saleh, I'm going to come back to you. So as somebody who's leading right now one of the biggest clusters in Saudi Arabia and is in the forefront, it's been about 7 years. How would you assess the journey thus far?
Well, I think it was challenging at first for probably one main reason is we had 165 primary care centers, but we only had 20 board-certified family physicians. So there was no way to really build primary care or prevention very well. Now we have almost 250. So that was probably the biggest challenge.
Serving a population of how many?
1.9 million. So we need almost 500. Now we have 250, but we're hiring at least 30 a year. So that was probably the biggest challenge. Now we're much better. We're working hard on establishing team-based care. Our other big challenge is rural health. That's where we are weakest for various reasons that you know. But
Dr. Saleh, so that you clarify this, your scope of work is not Riyadh city, metropolitan city, Riyadh city. It also involves what areas?
Well, from here until to Wadi Dawasir, 600 kilometers.
Yeah.
And there are so many villages, and it's just near to impossible to guarantee citizens who live outside of the big cities or middle-sized cities, guarantee them basic standard of care. And that's probably, no matter who you speak to, will tell you that this is truly the most difficult or challenging part. In the big cities or even the middle cities like Al-Kharj, things has improved much better. The concept of the medical home in the primary care center has developed significantly, where this primary care center has a catchment area of almost 30,000 plus minus, and they know the people in the neighborhood. They have won the trust of the people. You probably know that before that, almost nobody trusted the primary care center. Now, citizens have designated family physicians, and they actually chat with them on their health.
So I'm just cognizant of time. It seems like my timer is different than the timer here. It says 5 minutes, so we only have 5 minutes to contend with here. So Dr. Abdulaziz, from your perspective, what are the challenges that you think are facing you as a leader in your own system in transforming care?
There are a few challenges, and I'm sure there are ongoing plan to handle them. And but the things which worry me more is the people acceptance and willing to change. And when I'm saying people, that I mean I'm referring to healthcare provider. Accepting to change and the resistant to change is a well-known problem that faces people that they've been doing the same thing for the last 20 years. So they are a little bit worried and concerned about stepping out of their comfort zone, and they usually, some of them or majority of them, they will say things are doing well and going good, so why would you change them? And the role of the good leader should come and kick in, where we have really to drive that change and also make sure that the vision of the government, the ministry, and even the organization that the leader is part of is being transferred down to everybody in the organization, the frontliners and the people that really providing the care on the floor. And also opening an open communication with all care providers is also important. They need to be kept informed of what's happening around them and the change that's going around them. And again, there are so many techniques that can be done by the leader to overcome this resistance to change. The other problem or the challenge is the financial constraints. And I know that probably now most of the organization, they're either overusing their resources or underusing them. And in both situations, this is a problem. So if you are really, there is no efficient way of spending and planning your resources to provide the care, or even if you ask more than what you need. And these are the main problems.
Thank you very much. So we have less than 3 minutes, and in the last few minutes, each of the panelists, if I can ask them in less than a minute, just think of the future. Think of what exactly is your wish list of things you want to have to actually transform care moving forward, taking into account the journey thus far, but also what exactly is your wish for the future? What do you require for a successful transformation, in, if possible, in less than a minute? Dr. Ali?
Well, less than 1 minute, but if I have a long wish list, I will.
Yeah, the key ones.
I think it's focusing on population health, focusing on cost-effective approach to these population that are in need, especially when our colleague were talking about rural areas, reaching a huge country like Saudi Arabia with all these small villages, small clusters of population there. I think having what do you call it, the virtual care on top of all the care that we are delivering to these kind of population, empowering these communities to understand what's the challenge that they have, and also working with our workforces to understand also the model of care to these small communities that are scattered around the kingdom.
Dr. Abdulaziz, in 20 seconds.
In 5 seconds. I would say invest in people. I think my wish list is to have a proper investment in people and staff and healthcare providers that can take that model of care to the next level and continue. When I'm saying investment, that means an open learning environment, opportunity to get more of training courses, to get more physicians, graduated training programs, healthcare providers at all levels. So invest in people.
Invest in people. Dr. Saleh.
So better funding for primary care centers, adopting best digital health solutions, and doing better at engaging citizens in the model of care and building their sense of ownership over their health. Thank you.
Thanks.
And for me, I think it's seeing a radical transformation in the way healthcare teams are structured and organized. In particular, the way our hospitals are organized. I think if we don't see a radical transformation in the ways our hospitals are organized, are structured, how teams are organized within healthcare systems, I think we might risk basically duplicating many of the efforts, wasting lots of resources, and not achieving the impact of the model of care that we want to achieve. Many of the resources that we have are locked in old-style organizational structures that need to be dismantled, in my view, to allow for new ways of organizing that are patient-centric, multidisciplinary, outcome-focused, value-based, and that needs a lot of work to be done.
So in summary, I think the key points here is that, first of all, invest in people, change their mindset, obviously, towards the right mindset, adopt a learning environment or create a learning environment for people to actually grow. We need to think about how teams work together. So the structures really need to be challenged. The current structures, the command and control approach towards care delivery. Command and control doesn't work, generally speaking, but it definitely doesn't work that well in healthcare if we wanted to actually transform care. So that's what you're saying. Community delivery of care at the community in primary healthcare center, that requires a great deal of work. And then ultimately, bearing in mind by leaders in these hospitals that it's not about care that is being delivered in the hospital, but it has to take into account population health. And that population require, if we were to actually move towards the outcome of that we aspire to and our leadership aspires towards life expectancy, thinking about population health management is really indispensable. It requires to be in the center stage. So here you have it. These are the key wish lists or key enablers or prerequisites for a successful transformation. I think there's a lot of success that happened in the last few years, a lot of efforts. The question really, is this enough to carry us to the expectation of our leadership, to the national targets? I think that's something that we need to ponder on, we need to think about. With that in mind, I'd like to thank distinguished panelists for their contribution and their wisdom in talking about the model of care, and I'd like to thank you all for your attention.
Welcome back, Ms. Jackie Rock, our moderate for the next spotlight session, Leadership in Action, Catalyzing Integrated Care Transformation. This session will focus on the critical core of leadership in driving integrated care initiatives, emphasizing how visionary leaders can foster collaboration and innovation within healthcare systems, exploring strategies for overcoming barriers to transformation and enhancing healthcare delivery. Please welcome Ms. Jackie Rock and Lord Nick Markham.
Hello, hi everybody. Now we're going to get into some really interesting topics on leadership, because everything that we've been talking about today requires really insightful and very focused leadership. So I'm delighted to be joined by my good friend, Lord Nick Markham.
Thank you for having me.
Yes, and so Nick, let's just start, explain a little bit about your role as the Health Minister in the UK government, and a little bit about the context of what it was when you landed into that role.
Yes, thank you. So, yeah, I'm not the first thing is I'm not a politician by background. So I'm a business guy, particularly in the tech space. So for the last 20 plus years, I've been doing tech entrepreneurial stuff, lots of startups. And it was really one of the things during COVID where I pioneered testing and really got the sports and TV and private sector going again, that I was asked to become a health minister about 2 years ago. Thrown completely in at the deep end. Wasn't really given any briefing about it all, but I was given all the responsibilities around the technology space, finance, capital and commercial, given my background. And I have to say it's really hard. I mean, it is. You know, you are started in there and you've got, loads of meetings, 16 meetings scheduled every single day. Getting yourself the headspace is really hard. And I think really, in terms of the environment I found myself in, the first thing I learned is the word national in National Health Service is a complete misnomer. So my favorite trivia question, and you know the answer to this, but to give you an example of this, guess how many different door types we have in the NHS? Can I have any guesses from the audience? How many different types of doors? I learned this because Jackie and I were running the new hospital program, and everyone liked to have their own hospital design. So can I have any guesses from the floor? How many types of doors do you think we have in our hospitals in the NHS? Any guesses at all?
10,000, is that?
Is that 50? Any more than 50? 100? 100, that's a lot of different doors. We've got 28,000 different types of doors. 28,000. And that's because people have their own ideas of what they need. And so we've got a highly fragmented system. So the whole thing about leadership is really, first and foremost, trying to get hold of that and drive change.
Brilliant, thank you. Yes, and I know about those 20,000 doors because I had to buy them. So, it was a really, as in any government, running the healthcare system in a government is really dynamic. It's ever-changing. The demands are very, very intense. How did you, Nick, go around finding solutions in that environment?
Well, I think what I found very quickly, and you're all dependent on data. I cannot stress enough, getting the right management information is critical. But what we saw is our hospitals have really become the place of the last resort. So it's the place that everyone can go to because they know they can get care. So, we found out, for instance, that half of all our ambulance call-outs don't need to take the person to the hospital. So you can find other solutions to them. You know, they're often because people have fallen down, and so you can just have a full service to pick them up instead. 50% of people who go to accident and emergency don't need to be going to accident and emergency. They're only going there because they can't get primary care. We found that 60% of kids under 10 who are going there for dental treatment. Again, they don't need to be going to hospital about that. So what it is really all about is finding out, you know, what are the root causes, and then trying to put different solutions in place, working with the teams and saying, okay, what are the initiatives we can do in each of these spaces?
And a similar question to what I asked Dr. Giles earlier this morning. You know, how did you, as the health minister, you've got a very complex and dynamic health system. How do you bring everybody along to sort of the national objectives and vision and mission that you're trying to land?
So I think it's all about prioritization and finding out what are, you know, there's only probably, as a minister, 3 or 4 things you can realistically do. So it's really picking what are the big wins that you can really do, and being very clear and determined and get everyone behind that. So for us, it was technology. And again, fantastic working with Jackie and Tim that you heard earlier, in terms of really believing that the power of the app, we had 33 million users, and using that to shape the way people undertake their own health and manage their own health was massive. Because we had a whole problem that everyone was managing for their own individual budgets. And what they were doing for their budget might be right, for their own individual hospital or doctors, but across the piece, it was, you know, it meant that costs exploded. So all of a sudden, making it patient-centric, and the best way to make anything patient-centric is by giving the power, the person in their fingertips, to make it about them and the treatments that they need. That then drove the whole delivery around it.
And so you mentioned about as a minister, the sort of the 3, I think you said 3 or 4 things that really you can focus on. You mentioned tech, which I assume is a big win. What else will you take from that experience that was a real big win?
I mean, the key thing really is getting the treatment in the right place. So mainly it's about getting upstream in terms of integrated care. It's getting upstream of the problem. It is all about prevention. It's about flu vaccinations, COVID vaccinations, you know, all the public health programs. And it's about primary care. Again, the best practices we saw were all about putting the prevention methods in place, again, using data and technology to work out those who are at risk of a stroke or cardiovascular, and making sure that we got to them, gave them the treatments to avoid it. So those were the best things, and getting people behind that was the best thing to do. And really trying to look at what initiatives could we put in place to make sure that there was care happening in the right place in the community. Pharmacy First was a brilliant one, where, you know, we realised that actually there's 7 or 8 different pathways where you can much better put them in a pharmacy rather than people needing to go to the doctor. Created a whole new set of capacity and meant we could short-circuit the system. So really it was technology, prevention, primary care, and then different routes to market, such as Pharmacy First.
And what about, there's been a bit of a theme in terms of governance. I'll use the word mandation, but again, it's leadership of a, shall I say, you know, complex, fragmented at times health environment. How did you use governance and your role as minister to determine the outcomes?
And again, I mean, you're totally dependent on information to do that, and the data and the ability to do it. But you know, you notice that some systems have got just far better outputs, and it's exploring why is that. And again, it goes back to what we were saying before, that everyone wants to do it their own way. And it's saying, well, no, I'm sorry, that we are going to have a bit of top-down management and control. Now, you've got to have the good people and the good ideas to do that, so they have confidence in it. And again, that's where your leadership is absolutely massive. And then just saying again and again and again, no, we're going to do it this way. Yeah. And being quite forceful in terms of making sure that your agenda follows through on that.
Yeah. And, you know, I never like to look on the negatives of things, but of course I'm going to say, you know, what on reflection didn't work so well, and what would you have done different?
I think the main thing is just, getting people thinking about the whole system finance. So I had so many examples, I'm sure we've all seen it, where people are optimizing for their own budget. Ridiculous example last night, Steve, Phil and I were talking about it. Peasy midstream. It was this great bit of very simple, a lot of urinary tract problems. You have to get someone to pee into a cup midstream. Now that's quite hard when you think about it, again, without getting too graphic, but you've got to get it at the right point of peeing in there. And of course, what normally results is a bit of a mess and getting it wrong. And there was a very simple device where you can pee into the whole cup and it's got a spout in the middle of it. So you can just take the sample from it. That costs about 50p. The doctors would be buying something which would cost them a paper cup, which is, I don't know, pence, hardly anything at all. So they would be doing that to save their budget. But then it meant time and time again, you had to go and get another diagnostic test done because they got it wrong. So always people trying to save their own small piece of the pie and not looking at the savings over and above. And that's what the integrated care needs to be all about, is having people who are prepared to take that helicopter view, say, I'm going to invest upstream and save money for the whole system. And that's hard. I mean, again, in terms of hospitals, taking resources out of the hospitals and putting them into primary care and prevention, as a minister who gets it in the neck all the time if he's not doing it, that's a gutsy move. And so that's the real challenge in those situations.
Brilliant, thank you. And I know that you are, have great interest in the journey that the Kingdom of Saudi Arabia is on in terms of our healthcare transformation and our model of care. What advice, tips, lessons learned would you like to share with us? I think you cannot use technology too much. So I would say everything that we're starting to see about the app, we're now in a situation where a quarter of all adults use the app every month. And it's their whole navigation to the healthcare system. It can then start to do some of the things that Tim was talking about earlier this morning in terms of technology to give a diagnosis, without someone ever needing to see a physician. And so you can really free up capacity in that way. And again, if you give the people the power at their fingertips to understand their own health, they will do more research about it. They will find their best courses of treatment. They will take their own measures to prevent, improve their diet, stop smoking, stop drinking, whatever it is. Those sorts of things, so you can empower people here. That would be my biggest piece of advice. That's brilliant, thank you. And just finally, to get us back on track, time-wise, this was a session on sort of leadership. So are there any final thoughts on leadership in healthcare through such a massive transformation?
Continuity. It's really, really hard when people chop and change. That's be bold in your leadership. Be prepared to make mistakes. I've got my favorite thing, first rule of holes. When you're in a hole, stop digging. You're going to make a mistake. Say, I've made a mistake. Put my hand up, and work together to get out of it. But really be prepared to innovate and try new stuff. And that means you will make mistakes, but be decisive.
Thank you very much. Please show your appreciation to Lord Nick Markham.
Our next panel discussion is Lesson Learned Across the Ecosystem. This discussion will focus on maximizing patient experience, outcomes through case studies, personal experiences exploring key success, challenges, and leadership. The session will also cover how to maintain a momentum and align regulatory frameworks while considering future improvements. Please welcome Mr. Jim Griffith and panelists.
Well, good afternoon. We're very excited to be up here with you. We're excited to learn with you and from you. And to quote Dr. Ferris earlier, I think he said something very applicable that I'm finding to be very true. He said that the world can learn a lot from what you're doing here, and we are learning in real time with you. So we hope to take these next 45 minutes and bring the concepts of the Vision 2030 and the concepts of the model of care to the practical level. For practical lessons learned from operators from 3 distinct sectors within the Saudi healthcare delivery system. So we're very excited about that. To that end, we're going to begin with Dr. Faisal. And Dr. Faisal serves as the Assistant Deputy Minister for Hospital Services with the Ministry of Health. He oversees hospitals, specialized centers, and long-term care. He holds a PhD in biomechanics and has 18 years of healthcare experience, and is a very fun individual. We met just earlier and had a great talk. So Dr. Faisal, from your perspective, welcome. You have had a bird's eye view on the development of the model of care. Can you give us some insight on what it took to translate the model of care from vision to implementation, from concepts to being worked on a daily basis?
Thank you, James, for the introduction. And I hope that we all deliver an informative panel discussion to the audience. Back to your question, let's get back to 2015. Let's pause and think what was our situation at that time before the vision launched. We were having almost 260 hospitals with 4 oncology centers, 4 main oncology centers, all of them centers of excellence. We were having about 12 cardiology centers where they do cath and procedures and cardiac surgeries. No clear picture about the demand, the real demand at that time, because there is no complaint center. We can't hear. If you want to complain or if you have something or an issue, you have to go to the hospital director, deliver your speech in a vertical manner. We were at that time, I can say, hospital-driven or centric. Let's pause. And then April 2016, where our vision launched with 4 main strategic objectives for the healthcare. The first strategic objective to easing the access to care, improving the value of the care that we deliver, making sure the health promoted very well, and road traffic safety pillars. Started that time, almost now 8 years, we can say, since starting the vision. Plenty of initiatives and KPIs and projects. I'm gonna mention list of them, but it doesn't mean that all the initiatives. We started first having the mystery shopper, the cameraman, where they go to the hospital with their cameras to show us what was the service that delivered there. We started having a complaint center and then transferred into a call center. And now we received every single hour 150 calls. Try to imagine that. Yearly, we are talking about 1,200,000 calls, not complaints. Try to imagine without a call center. How can we hear the real demand? We started the National Health Command Center. It wasn't by chance. It was planned, and it's a fact now. The National Health Command Center for the headquarters at the Ministry of Health, where we have 8 platforms guarded by near to 100 screens to see what happened there and the healthcare delivery and monitoring the healthcare delivery there in the clusters and the private sector. Combining the referral center with bid management directorate and platform, where they are now looking at all of the kingdom, not only Ministry of Health institutes, where they see all of the referral center, and if a patient needs to be referred, immediately referred with a direct link with the medevac, if a patient needs to be referred. And we see the bed utility and length of stay in every single minute, not a month. So now, collectively, the list is actually, I will finish the panel without finishing the number of initiatives, but at least I can say to you now, to show that how the picture is clearer than before. We see now almost 300,000 patients in the emergency every single week. This means 1,500 patients every hour in the emergency. Try to imagine, without the platforms or without the vision, how can I get deep to know exactly the number of the patient per hour? We know for a fact that the complaint and call center improved the healthcare delivery, improved the value of the care that we deliver, as well as the mystery shopper actually helped us in the multi-sectorial level to know exactly what is the care and the level of the care from the angle of the patient, not only your angle or your leader's angle. As well as Brisgani, we hear from the voice of the customer, not only the patient. Now for the last 7 years, every single quarter we have a report from a third party, Brisgani, not from our side. Right. They call our patients or beneficiaries, and they know exactly what was their experience, and every single directorate or deputyship or someone accountable to a service, he knows exactly what was the voice at his level. So now we are still on the road. We did not finish, though we finished and we completed and we heard some of the initiatives, but still our passion is to reach more, to make sure that every single beneficiary get the right access to the care in the right time, in the right quality, in a safe manner.
Yes.
I hope that I answered.
Absolutely. Thank you so much for that initial question and your response. With respect to, you said something very important, that you've oriented your care around the patient, really listening to the voice of the patient, and that's just a wonderful message for any physician, administrator to design systems of care around the patient. Is what we attempt to do as well, so thank you for that. So all this work hasn't been easy, no doubt. So have you, maybe you've encountered a challenge or two, or an obstacle, but could you share what have been some of the major challenges along the way, and what maybe you've done to mitigate those challenges and accelerate the model of care?
One of the challenges is fragmentation of the service sometimes, and the centers that I mentioned, let's say an example of oncology. At that time, we were having only 4 main oncology centers, and then we realized that we have to get a good access. So what is the basic service for the oncology service? So we ended up with an idea of establishing a new chemo unit. It's a basic service. It will reduce the number of travel for the patients. So we start at the mega center or the big center. Patient continue his treatment is one of the areas that we improved. And nowadays we speak about 16 oncology departments that we have. Try to imagine, we started with 4 mega centers, and now we have 4 mega centers plus 16 oncology departments, all of them guarded by at least the basic service, which is a chemo prep unit. In the cardiology as well, we were having only 11, and now we ended up with having 28 departments for the cardiology because of we subcategorize the service. We still need the centers of excellence, but we don't need to have them in every single village. Right. So we subgroup our, let's say, healthcare delivery into mega or centers of excellence. And then for the cardiology, nowadays we have 46 cath labs. Every single city in the kingdom, they are guarded with a cath lab, which is a basic service of the cardiology. If a patient needs to be referred, planned, refer him to the mega center if you need. And nowadays, we don't need to send patients because we are sending our doctors. Yes. Try to imagine that we flip the coin, we send our doctors and our teams to the patient. So patient stay in his village or city and the doctor mobile to reach there. So from the challenges perspective, still, we are actually need to improve our proper documentation. Since actually we are now integrating our systems, every single hospital guarded by a HIS system. All of the primary healthcare nowadays with Raqim, which is a HIS system, unified HIS system for the primary healthcare. So now we are moving into an integration between the multi-levels and multi-sectors. We are on the road still. We have to finish the integration a bit earlier than expected because it affects the healthcare delivery. But the technical guys will work and will move into integration. But if the practitioner did not document and make a proper documentation, we won't be able to make sure that the service at that level is properly documented and we know exactly the proper demand for our patient. As well as from the challenges that we faced, geographic distances. Try to imagine from Al-Gurayat, from Al-Haditha, where we have a 50-bed hospital, in the corner with the Jordanian, under one umbrella or one provider, at that time, Ministry of Health, and now moving into the Holdco and its clusters. I can say one provider from Al-Gurayat to Najran, to Al-Khadra, to the corner of Yemen. So you're talking about almost 3,000 kilometers. So the geographic distances, it's limiting you sometimes to improve and to make sure that the services distributed in an equity manner.
Wonderful, thank you so much. But it sounds like the challenges are big, but you have been able to put in innovative solutions to really deal with those. And that's kind of what it requires, a new way of thinking to move the model of care forward. So thank you for that, appreciate it. Final question for you, Dr. Faisal. Public-private partnerships are a big part of Vision 2030 as we move forward with the healthcare delivery system. Do you see opportunities for better integration between the public healthcare sector and other sectors?
Thank you for the question. Yes, it's one of the areas that we are actually nowadays focusing and making a resolution on the private sector and other governmental entities, even the charity and non-for-profit organizations. If we are speaking about the last 60 years, we as a Ministry of Health were funding, regulating, supervising, and delivering a care. And nowadays, delivery is moved or about to be moved 100% to the Holdco and its clusters. So they will be accountable for the eligible patients. And we, as a Ministry of Health, we regulate. And then branches leader, which is actually nowadays, it's one of the corner business. They are the formal supervisor for the healthcare services in the region. So try to imagine we have now a directorate focused. One of their mandate to make sure the Holdco and the its clusters doing the right, let's say, protocols were actually passed from the ministerial level to the region, as well as making sure that the service in the private sector supported and making sure that the private sector doing the great job and improving their appetite and the other governmental entities like National Guard, Ministry of Defense, King Faisal Specialist Hospital, and non-for-profit entities. So now his main job to regulate, to make sure that the angle 360 in the region, and to support the let's say three angles or three providers level to make sure that the region is having a good access to care and making sure that the care is actually distributed very well, and they hear from the patient. They hear from the patient, not from the provider level. No, they hear from the patient. If anything need to be interact, they are the ones who interfere and to support and to raise any suggestions to the healthcare sectors, not only the Ministry of Health.
Yes, thank you so much. I think creating that, using the partnerships to create access for patients, absolutely important. So thank you, Dr. Faisal, for your perspective. We're grateful for that. Very important, very insightful. We're going to move now to a cluster, and it's the Qasim cluster, and we are grateful that Dr. Musa is here. And a little background on Dr. Musa. He has a background in pediatric hematology oncology and former executive director of medical affairs at King Fahd Medical City. And he's been the CEO of the Qasim cluster since 2023, so he's now going to give us a practical lessons learned from the very Qasim cluster. And just to give you an idea, the Qasim cluster has 1.3 million beneficiaries, 156 primary care centers, 20 general and specialized hospitals with a total bed capacity of 3,000. And that's a lot of beds and a lot of complexity. So we're looking forward to Dr. Musa's perspective on this. So first question for you, and welcome, Dr. Musa. You've been on a journey. You're going through the gates to become an accountable care organization, and then there's more work for you to do after that. But describe the journey for us, Dr. Musa, from the Qasim Health Cluster, the journey you've been on, and kind of why you think it's been working. Please.
Thanks, James, and I would like also to welcome all our colleagues here. I think the journey was started in Qasim 2019. I think my colleagues really work hard. I think the reason for the success at that time also, the right structure for the cluster itself, the right people, also the right action plan, and the right way of execution of this plan. So my colleagues really work hard over the last, let's say, 7 years to achieve the maturity. It was enough at 2024 to move and to give a readiness and to give a green light for the cluster to go for to move from the Ministry of Health to the HALDCO. I think if you ask me what has happened during this time, I think there is many factors, and the most important is the implementation of model of care, and also the implementation also of the service line, also the implementation of the following exactly the manual for the ACO. I think this is give clear directions, and that really lead to the acceleration of the way they moved and they cruised through the transformation journey. It is very important also to give time to time some, let's say, quick win can be seen by the patient and can be seen also by the staff themselves to feel the transformation. I think one of this a great achievement, it was what happened in the service line of the cerebrovascular accident and also the cardiac attacks. For example, a patient with a cardiac attack, for example, used to stay around a day almost to be transferred and to be treated and to reach to the cardiac center. I think after the implementation of the service line and all the hospitals work under one umbrella, they contribute to each other and they complement each other and collaborate also with each other. And the service line observing the movement of the patient, we are resulting in movement of the time to the cath within 40 minutes. And Qasim is in a large area, and this is happening now, and all the patients treated and discharged in a very efficient way. Since all these factors lead really to give the maturity for the cluster over this short time. Thank you.
It sounds like you're organizing the service lines around for the benefit of the patient, which is very important work, very important. So thank you for your overview of your journey. Another question for you, Dr. Musa. What were some of the key initiatives and efforts that led to the success of your clusters? Any specific initiatives that, as you look back, that was instrumental in the advancement of you moving through the 4 gates? For example, you just passed the 2nd gate for your Cannibal Care organization, which is to be celebrated and honored. But what are some of those key initiatives that we would all learn from here?
Yeah, I think we have a lot of initiatives, actually. And I need to spend days, really, to express my colleagues' work in a lot of the initiatives and in all aspects, all pillars of the model of care. If you want, because of the time, maybe I will give 2, for example, examples. One of them is the stroke pathway. And we're working in time where the stroke patient will be managed in the peripheral hospital and without an expertise and to guide him and to guide the treatment. Nowadays, we have a very mature surface line where the patient will be moved, CT scan will be done in a few minutes, and he will be seen by stroke consultant, and he will give him the thrombolysis therapy within a very short time. And if he's eligible for the thrombectomy, we have this advanced surfaces now in 2 centers in Qasim. So one in Breda and one in Anaiza. So this is, I still remember now, the last week, a patient came with complete hemiplegia, and he discharged after 1 day walking in his hand. I think this is really give success and give really the good feeling for the staff to continue this journey. This is one of the examples of the success of the service line and pathway, and reflection also the urgent care implemented by the also the model of care. Another success story is also for the screening programs. We have a lot of screening programs, for example, for the hypertension, the diabetes, thousands of patients screened. And at one point of time, we don't see these numbers, hardly to get somebody screened, even if he visit the physician or he visit the primary health care centers. Now it is very organized. There is a dedicated people to do this screening. The better example also of screening is the screening for the breast cancer and the colon cancers. Thousands screened. We have a lot of positive cases detected in very early stages, treated with less cost and a better hope for the survival. I think this is initiatives, and this is a work which should be appreciated for everybody working with it, including my colleagues really in Qasim, because they save a lot of lives.
No, thank you so much, Dr. Musa, on that. Absolutely. I think as I think about some points of application, but just keep ensuring that we have access for patients, that we ensure that we're bringing value to patients, that we are eliminating any type of waste within their patient care journey, but also taking care to them. Matter of fact, one of the things that we have done at the place where I come from, we have a mobile clinic and a mobile mammography center. We are going out into rural areas to ensure that we take care of the patients with the same equipment we're using in our main facilities. But I appreciate your examples. We can learn a lot from those. So final question for you here. What are the top 3 lessons you've learned during this journey that may benefit, other sectors that are listening here today?
Thank you to give me this chance also, because such event where we talking about the really specialists and administrators from all sectors in healthcare, including the public, including the Holdco now, and all the military and the private. I think one of the beliefs that I asked for it also, to have implementation of the model of care for all the sectors. And what I hear with today, it's coming, inshallah, and so on. So this is, I think, it's very important, because that will concentrate in the population health more than the patient himself. because our system before used to go for the patient, treat the patient whenever he comes to you. I think we have to run behind the patient to detect them early, to prevent disease, to screen them. If they need the service, we'll bring them to either, according to their need, either to the urgent care or the chronic disease, or to organize their services away, and at the end of life module. So I think the model of care should be implemented in all sectors, and to have a competition in that. I think this is I think today the exhibition is one of the evidence for that. The other thing I think is also the implementation of value-based care. I think this should be a direction, because we are all the sectors moving toward the value-based care. I think we'll start from now to implement the initiatives for quality, efficiency. If we want to concentrate on one thing, also the access of care should be affordable for all patients. Yeah. The third thing I think that's also help us during transformation, the change management itself. We have a lot of transformation going on, a lot of commitment for the leaders, for the staff, for the frontliners. And I think here the key thing is the communication. I think leaders should communicate in all directions, not also in the C-suite only level, but they go and to meet their colleagues, the frontliners, express the journey, where we are heading, what is our destination. I think this also will help also to in the transformation process itself and to reach our goals. Maybe this is the three pillars.
I'm going to come back to that. Dr. Files, you had a question, please, or a comment, please.
Yeah, a comment to support what Dr. Musa's comments. When I mentioned the cardiac centers and expanding, the main aim was to ease the access. And when Dr. Musa mentioned about their, let's say, initiatives within the Qasim clusters, collectively, every single region now, they have initiatives to reach to the patient at the right time. Nowadays, we are talking about 82,000 caths a year. 5 years ago, the number was only 40,000. Does this mean that we are getting a disease more? No. We are easing access. Why? Because we are connecting the Red Crescent car. They go directly to the cardiac center. They don't need to go to the hospital. So now it wasn't by chance, no, it was planned. The Qasim is one of the regions actually focusing on getting clearer access to the cath a bit faster than the usual way. This was under one of the vertical files for the model of care. We call it urgent care. I will give you another example for a destination or a chronic or a palliative care. We have a program called Home Health Care Program. Nowadays, we have 512 cars. Try to imagine that, 500 cars guarded by thousands of practitioners serving patients in their homes. Nowadays, we serve 53,000 patients at their homes. Let's imagine we don't have the program. What would happen to our hospitals? 100% occupancy rate. 100% occupancy rate. Nowadays, we serve them there. And if they are in need for any virtual care, easily we can connect them within the region or within Sahha Virtual Hospital. Sahha Virtual Hospital got the Guinness Award a month ago, the biggest virtual hospital in the world, now supporting all of the regions if they are in need for a virtual care.
Thank you for those follow-up examples. Much appreciated. And if we could come back to change leadership at some point, we will. But everything is changing. Healthcare is changing. And teaching leaders how to lead that change through change management classes is a big emphasis we have back in the States there. But I appreciate that thought. Thank you for your innovative comments there. So, Engineer Noor, we're so thankful you're here as well. And you're going to give us a unique perspective from so many unique aspects of your background and what you've done. But I want to say welcome. And you serve as the Chief Transformation Officer at King Faisal Specialist Hospital and Research Center. She's a former VP of Strategy at SDIF, part of the Strategic Transformation Office at Saudi Aramco. And Schlumberger Field Engineer, she's been, and has driven transformation initiatives across industries. And there's so many exciting things going on at King Faisal Hospital. I don't have time to list them, but it is an incredibly innovative place. We're so glad you're here. First question for you. how does the model of care impact your focus as the Chief Transformation Officer responsible for much of this change of a thriving healthcare system, please?
Okay, Bismillah ar-Rahman ar-Rahim. Thank you so much for having me on this panel, first of all. KFSH is similar to the themes mentioned by my colleague, moving from your traditional metrics to patient-related outcomes as well as patient experience. We find that those are going to be huge inputs, very important in terms of decision-making based on patient-reported outcomes, as well as all of the enhancements that we're going to be working on. We still intend to focus on specialized care, but we're already moving towards a new kind of model of care that is centers of excellence. We've already reorganized. We launched this new system beginning of the year, where we have 8 centers of excellence made up of multidisciplinary teams that are focused on transplant, heart, women and children's health, surgery, medical, genomics, and neuroscience. I always forget neuroscience. And the way that those teams are set up, it's to be much more collaborative, focused on patient needs and patient experience. Rather than having the patient go to wherever they need to go, everyone is kind of centered around the patient to make it easier and more accessible for them. So the teams will collaborate, the infrastructure should support. We're trying to also push down the ownership and accountability to the heads of the centers of excellence so that they are responsible for their P&L, they are responsible for their people, and they have their own kind of research and education function, because it's really important to integrate all of that as well. And we're also very keen to understand how the rest of the ecosystem players are working as well and what their strategies are, because it's very important that we work together in this system. We're very focused on the specialized care, but obviously how we refer patients to each other, we're part of a bigger system.
Yeah, absolutely. Yeah. It sounds, what I'm hearing is that the systems of care, the service lines are so important to bring this concept of transformation from a high level down to the patient level. So appreciate this from all of our panelists here. A second question for you, Engineer Noor. As a result of the model of care, what are the key focus areas for King Faisal over the next 12 to 36 months? Where are you going to focus your time and efforts in the midst of everything that you've got to do?
Okay, so maybe a little bit of context first. King Faisal Specialist Hospital is already considered one of the top hospitals in the region. We have been asked now to, with the increased ambition, to take this amazing organization, institution, and make it one of the top 10 hospitals in the world by 2030 or beyond. And so what that means is, based on the Newsweek ranking, we're currently around the 200s. We expect this year, when the rankings come up, we'll maybe make it around the 100s and slowly make our way up to top 10. And we believe we can do it. When we looked at the current top 10 hospitals, we found that there are 2 main characteristics that kind of make them where they are, or put them at the top where they are. The first one is focusing on the synergy and collaboration and coherence between what they call the triad, that is healthcare, research, and education. The second thing is focusing on 11 dimensions that I'll go through in a minute. But if I pause and talk about the healthcare and the education and the research, there are areas that we are already doing really phenomenal in. Some people know about it through word of mouth, and others maybe have heard, maybe in the region where people are aware, but you'll start to hear more about what's going on in King Faisal Specialist Hospital. As you saw recently, the first fully robotic heart transplant, the first fully robotic pump that was also done. Last year, there was the first fully robotics liver transplant, and when I say first, I'm talking first in the world. Nobody heard about the liver one because we weren't really focusing on the branding, and that's a big part of getting people to know about what you're doing. So we're really excited about that because there's already amazing things happening in healthcare. We are actually almost on par with a lot of the global hospitals, but nobody knows about what we're doing. So you'll hear more and more about King Faisal. On the research side, there's still a little work to be done there. It's one of the areas that we need to really invest in. We intend to double our publications. We intend to 10x our clinical trials. So there's a lot of work to be done there. In education, we also want to strengthen our ties with a lot of the universities and create more integration between the curriculums that go into research and then obviously support our healthcare areas. On the 11 dimensions, these are areas, in addition to these three, that are, for example, HR, infrastructure, IT, governance, financial sustainability, which is really important, branding, as well as operational excellence, and most importantly, and at the center, is patient experience. And it's really important to note that the top 10 hospitals excel at all of these. And so there's a lot of work that's being done across all of these areas. Some areas were okay. We need to improve a bit more. Other areas, there's a lot of work that needs to get done, such as research. But those are going to be our main focus areas in the next 12 to 13 months.
Yes, I'm interested in those 11 areas because I think, you know, reporting and the key performance indicators around those 11 areas are going to be very, well, just vital to making the changes. And that's something we struggle with, is getting the right data.
Absolutely.
To show that we're making progress or not and measuring that progress. But
Absolutely.
Final question in our last few seconds here. Leveraging your vast experience across multiple industries that you've worked in, reflect on the common themes and requirements really for successful transformation that could be applied by many of the folks in the audience as we close out.
Yeah, so I was responsible for the transformation that was done in the Saudi Industrial Development Fund, which is a very different industry. It's financial services, industrial sector. Prior to that, I worked in Saudi Aramco in their transformation office, so oil and gas, very different as well. Now focusing on healthcare, I think there's a lot of commonalities across all the different sectors. So one is communication, communication, communication. You cannot over-communicate. I think it's really important to keep people involved. It becomes really tricky when you still haven't made decisions and you don't know exactly where you're going to go. But I think it's worth, what we try to do at the hospital right now is we have monthly town halls. We have a lot of workshops. We have a lot of meetings. We share everything that we're working on and we say, look, this is the direction that we're going in. It might be different the next time you see it, but at least you know, at least you're in the kitchen with us while we're designing all of these things. A second really important thing is buy-in. So it would be really easy to hire a bunch of consultants, with all due respect to consultants, and outsource the work, have them do the work, and then, you know, come back and try and implement it. But that would just never work. Because the people that are going to be implementing and the people that know the organization most are the employees, are the leaders that are in charge. And so it's really important to get buy-in, ownership, which is also something we're trying to implement. Complementing with, you know, external expertise in certain areas that, you know, we might lack is okay. But I think it's really important to have our employees, our physicians lead and own and take charge and be fully accountable. The other thing I noticed is also in organizations that are very well established, so both SIDF and King Faisal Specialist Hospital are, King Faisal Specialist Hospital is celebrating its 50th anniversary this year. So it's a very well established organization. It's already done phenomenal things in the region. And so people that work there are very loyal and they love the organization so much, which for me makes it a lot easier because in any transformation, you deal with people that are resistant to change, that don't want to change, but the reasons are usually, you know, they're very comfortable in the way that they do things, or they don't want to do the additional work, or any of these reasons. But when you have an organization like King Faisal Specialist Hospital that has done so much for the community, that has done so much for the people, the reason for resistance is loyalty, is fear that you will take this organization and damage it or ruin it. And so all you need to do with those people is, again, communicate, inform, get them on board, and then you immediately have this army of supporters that will drive the change as well.
Absolutely. Yes.
And I think
Yeah, we'll finish up
one last point, sorry. So I think those are the maybe common things that cut across different sectors and industries. But I think what makes the health sector very unique in terms of transformation is in any other sector, when you want to make changes to systems or processes or the basic things that happen, the worst thing that can happen is you get a disgruntled client if you've messed up the form or done something different. Whereas in the healthcare sector, if you make a mistake, even if it's in supply chain or appointments or things like that, lives can be impacted in a very, in a very scary way. And so there's a lot more focus in the healthcare sector. There's a lot of need for a lot of redundancy. You have to be very careful. You have to take a lot of, cautions. But I think those are the things that kind of make it a bit different.
Thank you so much. We could talk a lot about that. And we could talk a lot about a lot of things, but we are out of time. I just want to say thank you so much, Engineer Nawar, Dr. Faisal, Dr. Musa. Great. It's an honor to be up on the stage with you. I think we've all learned a tremendous amount. I just wanted to give you a round of applause and thank you so much.
And now, we will take a lunch break. Please be back at 2. Thank you for your engagement and attention. You will find the prayer room just next to the lunch area. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back, everyone. Our next session is the power of prevention, revolution care through learning health systems. We will explore how lifestyle-centered care can use prevention strategies to transform healthcare delivery. Our speaker, Mr. Wayne, brings extensive experience from his career in New York, Chicago, and Texas. He will provide valuable insights into how data-driven approaches can enhance patient outcomes. Please welcome Mr. Wayne Keithley.
There we go. Good afternoon. First of all, I want to thank the sponsors and organizers for inviting me to speak at this conference. I must say it was very impressive this morning. I learned a lot, and I feel like I will try to return the favor, but you had some great speakers, great panel discussion, and it's certainly cutting-edge discussion around model of care and the things that, frankly, apply to the work we're trying to do in the United States as well as what you're accomplishing here in Saudi Arabia. So I've probably got the in my opinion, one of the least exciting and probably most disappointing, but unbelievably important topic for today's agenda. Lifestyle-centered care is the rough equivalent of having your parents tell you to eat your vegetables, do your homework, and go to bed early. And it's got about as much appeal, frankly, as that kind of advice, which many of us got as children. What you'll see, though, and what I discovered in doing my homework for this today's assignment and speaking engagement, is that the results for it, though, are pretty profound. And the good news is that you'll see that there are some powerful tools that are available to health systems and providers today. The bad news is that you'll discover, as I did, that they're not being used effectively or appropriately, or at least consistently so. And again, I speak largely from my experience in the United States, but I think that's pretty much true globally, and we'll talk a bit about that. So by way of full disclosure, I should probably tell you that in some ways, I'm one of the least qualified people to talk on this subject because I spent my entire career working in academic medicine, basically trying to build and advance tertiary and quaternary clinical programs. And those are in some ways, as you know, the kind of the antithesis of what we're talking about. There's a phrase that often refers to the kind of medicine delivered at academic medical centers called rescue medicine, which basically says that for a variety of reasons, people who have made bad choices, who had bad luck, who have bad genes, or a variety of reasons wind up, frankly, being snatched from the jaws of death by all the amazing things that academic medicine can provide in the United States. And I've worked for those centers, and they do amazing things. But what's become clear in looking at some of the numbers from today's study and the things we're going to talk about is that a large majority of those patients, in fact, didn't have to be there, at least didn't have to be there with those chronic conditions. So it's important to remember, again, that in some ways what we're discussing is the opposite, really, of what is being delivered in many of the American medical institutions, not really what is necessary. So this, the data on this slide is a little bit dated, but not dramatically so, and I suspect that the numbers are probably even more dramatic today in 2025 than when this report was published. There was a landmark study published in the Journal of American Medical Association in 1993 that estimated that 80% of the premature death in the United States was attributable to poor lifestyle-centered choices. The percentage today is as high or greater. This is a global problem. For Saudi Arabia, the effective lifestyle directly contributes to rates of type 2 diabetes estimated to affect 4 million of your citizens and the adult population, and those are just the diagnosed cases. Rates of adult obesity, a major contributor to poor health, is roughly 36%. And diagnosed hypertension, the so-called silent killer, at roughly 24%. These are estimates from 2015, and again, no doubt greater. But the problem is not unique to Saudi Arabia. It's not, and what surprised me, frankly, in the comparisons, is looking at places that I've worked. Texas, the home of the Texas Medical Center, the largest medical center on the planet, has rates that are equal or greater than those that you see in Saudi Arabia. The same is true in New York, and the same is true in Chicago. Now, there are slightly different reasons for that, but the same burden of chronic illness is just as high in those communities as what you see in your own. And we'll talk about some of the things that have been done there and the ways in which they've been successful and the ways that they've struggled. One thing to remember is that there's nothing new about the advice around lifestyle-centered choices and the effect it has on reducing the burden of chronic illness. And there's really nothing even new necessarily about some of the tools and the initiatives that have been formulated to try to address it. I'm hopeful that by the end of it, though, we will collectively discover that some of the new tools available in other aspects of medicine are beginning to be more helpful, though, and perhaps giving us a chance to make these things sustainable. So I started working in Houston, Texas Medical Center first back in 2014. And when I got to town, I was working for the Baylor College of Medicine, and someone welcomed me with the expression, "Welcome to the Houston 20." Now, at the time, I had no real idea what that meant, but later discovered that the Houston 20 is a phrase that they use to welcome new citizens, and it refers to the 20 pounds on average that people moving to Houston will gain from living there. So you may remember in college, we were warned about the freshman 15. Well, Houston has the Houston 20, and it's a true statement. As I said earlier, the rates of obesity in Houston are every bit as high as you see in Saudi Arabia and other communities that struggle with the burden of obesity and the consequences of diabetes, exactly the same. And it's just ironic, though, given that Texas is probably one of the best served communities in the United States with respect to tertiary and quaternary health care. So what you'll discover, what I discovered, is there's no clear connection, no favorable connection anyway, between the presence of tertiary and quaternary care and being able to effectively address the burden of chronic illness. The advice around preventive illness and preventing chronic illness actually is also as old as those studies I mentioned earlier. And they come down to basically the basic pillars of lifestyle-centered medicine. Essentially, predominant whole food, plant-based diet, physical activity, restorative sleep, stress management, avoidance of risk substances, tobacco, mostly, and alcohol, and positive social interactions. There's nothing particularly magical about those things, but the evidence is clear that they are effective in reducing the risk of chronic illness and therefore preventable death. There are many examples across the country and across the globe, actually, of very successful programs, including some, by the way, in Saudi Arabia, in which you can clearly demonstrate that if these initiatives are applied at the community level, that they are effective in reducing the burden of chronic illness. They are effective in lowering the cost of care, and frankly, they are effective in reducing the demand for acute and tertiary services. So there's no shortage, actually, of examples that this works. So you might ask yourself, well, if we have the diagnosis, and we know that there are treatments that are effective, then why aren't they sustained? Why haven't they had the effect that you would assume they would have in managing a population's health? We'll talk about that in a minute. I want to give you a couple of examples, though, of programs that I'm familiar with. So this is a model that was developed at Rush in Chicago. It harkens back to a study that was conducted many, many years ago, which talked about the so-called death gap. So the death gap in Chicago is an observation that the average lifespan of patients living plus minus 2 miles from one another differed dramatically by something like 15 years. And what they discovered at Rush is that part of it had access to healthcare, part of it was access to healthcare education, part of it was just simply the availability of providers in primary and basic care. And we're talking about really basic things. In some instances, just even whether public transportation was able to get patients to providers. So they were completely cut off from any aspect of supportive medical care. So Rush set out to do something about that. And that project has been ongoing for many years. It was interrupted, sadly, by the pandemic, which set them back somewhat. But they've made tremendous progress. Now, what they discovered, though, by the way, in it, is that it wasn't necessarily a function of expanding the medical footprint. It was a function of addressing social determinants of care. That's a phrase that you've heard already this morning, and you're going to hear more and more, I suspect, as we talk about what we need to do in terms of addressing some of these issues. The social determinants of care have a lot to do with the relationship between the healthcare provider and other community agencies, has a lot to do with transportation, has a lot to do with the social network that supports patients, providers, and the institutions that serve them. One of the things that we have, that I've noted, by the way, which I think makes it relevant for today's conference, is that in Chicago, of course, we're looking at communities that are all in an urban environment. So they don't have necessarily the same dynamics that you would see in Saudi Arabia, but they do compare very similarly, frankly, to differences between urban and rural environments, something that, again, I know one of the panelists referred to earlier as being an issue for you. So you have the same sort of challenges, as we do, by the way, in the United States in rural communities, as you do in places like Mississippi, Western Alabama, and so forth, where, frankly, you have access to tertiary and quaternary services, but not available to everyone simply because of the location. So this is, there are profound similarities to this, frankly. So basically, Rush developed a program where they addressed the social determinants of care, tried to expand those services and make them more available to patients in the community. And they made tremendous progress. Again, the pandemic was a bit of a setback. And not surprisingly, they noticed during the pandemic that those patients from those communities also had higher morbidity and mortality as well. New York City Health and Hospitals Corporation has launched similar projects. This one I'm very familiar with. It addressed some of the healthcare concerns and issues around health equity and clinical outcomes in some of the boroughs, Brooklyn, Queens, and so forth. And they found essentially that these were the key elements, if you will, to being able to enable healthcare and secure better outcomes for patients in those communities. What surprised me about the list is it had less to do, again, with tertiary quaternary services. It even had less to do, frankly, with the availability of primary care clinics than it did with some of the basics that just enabled and supported a healthier lifestyle and the ability to get healthier choices. One of the things that a lot of the studies coming out of New York, Northwell Health and Hospitals Corporation, discovered is that advice that is not empowered, in other words, if you tell someone these are the healthier choices you should make around diet or nutrition, but in fact they are unable to access or act on those choices, then it's useless. It makes no point. And I think that's a problem that, frankly, we all face. That's one that I've even observed in the communities where I've worked and lived over the past 20 or 30 years. That if you provide advice around, well, you should eat this, you should avoid that, you should try to exercise more or have a more vigorous lifestyle, that unless there are means for doing so, then frankly, it's just hollow advice. It doesn't work. And that's probably why some of these programs during a study period can succeed, because there are resources applied to it, but when they're withdrawn, they fail. And I think that's something that I'm sure you've observed here as well. The community-based programs really have a lot in common in terms of the characteristics that seem to make them most effective. The first and foremost, by and large, is having them connect to other community-based organizations. And I think that was probably the most important lesson that we learned in Chicago and the one that the Health and Hospitals Corporation learned in New York. They can't operate in a vacuum. That in fact, we tend to think of these things as healthcare problems, issues, and challenges, but the reality is they often have to do a lot with what's available in terms of other community resources as well. That's what makes them work. And we spent a lot of time, frankly, building some of those programs, strengthening some of those community resources in these other communities. Now, the good news on the horizon is that you say, well, we know the diagnosis, we have therapeutics that work, but these programs, by and large, aren't sustained and don't last over time. The reason has a lot to do, frankly, with engaging, empowering patients and their families, giving them the information that they require, giving them a means to be able to exercise it, and frankly, being able to support them with information and feedback and allowing them to take control of their health care. I think that what's on the horizon for us in this regard is the use of AI-empowered tools. One of the earlier speakers talked about some of the things that we can do in terms of chatbots to be able to communicate better with patients and sort of replace, if you will, the traditional access to physicians and nurses that sometimes is a constraint. And so a lot of this work is being done even in some of the communities now that I see in Texas, where access to care because of the medical center and otherwise is not such a big issue. But applying technology to this has been very, very promising and helpful. The role of healthcare professionals is a critical thing to be addressed in all of this. You know, the healthcare systems today are organized around and are acute care and tertiary care centric. That's the way the physicians are compensated, that's the way they're structured, that's the relationship that nurses have to physician providers and physician extenders. My view is that in terms of the model of care, we need to rethink how that's organized if in fact we're serious about lifestyle-centric choices and around preventive medicine. Our systems, and I speak for the ones that I've worked for and the ones I'm working for now, are not organized to empower, to compensate, to incentivize providers or the system itself to be able to meet these needs. In fact, the financial structure and reimbursement structure of healthcare in the United States does not at all support this model right now. We're basically a fee-for-service, activity-driven enterprise with few exceptions. And that will have to change, frankly, in order for this to get the attention and the resources that it requires. So, challenges and solutions. First of all, I believe that this is all very social, cultural, ethnically centric. It has to fit in, whatever solutions we have to fit into the fabric of that society that it serves. It will have many things in common, but there are going to be some critical differences. And so I think you start with the community. You start with what works in the community and how to make that more effective, and then you connect it to the healthcare system that goes with it. You have to have mechanisms by which you educate the patient in order for them to be empowered, to make them autonomous in their care. They've got to know what choices they're making. They have to understand the consequences of poor choices, and they have to have the tools to make wise choices and access to those resources. So that requires a level of social planning that, frankly, most health systems have not yet provided. So I think the future is really promising in this field. I want to tell you a real quick story about the metabolic clinic at UTMB, University of Texas, where I am now. So we have a metabolic clinic that addresses morbid obese patients. Everyone's very excited about GLP and about the role that it's playing in weight loss reduction and managing hypertension and reversing even early stage kidney failure. And it just seems to be this amazing, amazing wonder pill. The problem with it, of course, is that it requires to be effective long term. It requires a rigorous exercise program. It requires a commitment around every other aspect of health. So this class of drugs has the potential to be a magic pill to actually address many of the problems that we've talked about with chronic illness, but only if it's combined with a full treatment plan, a lifestyle plan that supports and enables the right kind of activities that go with it. And I think that we're going to see next and future generations of these drugs that will be even more effective, but they will pose a greater risk than a benefit if not combined with that system. And I believe you've already seen this in Saudi Arabia. I know there's some off-label use. I know there's some use of the GLP class of drugs without physician support. So those are the kinds of problems that we face. I will also tell you that in a discouraging note around patient compliance, one of the things that we've already seen in the metabolic clinics is that patients are actually so non-compliant on GLP use of drugs that they default back to bariatric surgery. I want you to think about how low that bar is, that you have patients who are not even compliant on taking a drug once a month or once a week, that they have to default to a surgical option because that's a better choice for them. So I think we have a lot to do in terms of educating patients. We have a lot to do in terms of empowering them and giving them access to better choices. And we certainly have a lot to do in establishing the level of discipline required for them and providers to make this effective. I know that was whirlwind, and I apologize, and I know that it's mostly bad news, but there's a little light at the end of the tunnel there. So please focus on that as I did. Thank you very much.
Our next panel discussion, measurement to drive successful model of care implementation. This panel will explore how to define and measure success in implementing the model of care. Panelists will discuss perspective on success, focus on clinical quality, patient outcomes, and workforce engagement. Please join me in welcoming our moderator, Dr. Saad Al-Asiri, and panelists.
Assalamu alaikum. Ladies and gentlemen, good afternoon. It is so beautiful day, and it is amazing to see all our colleagues here. And it was really a pleasure to meet all of you, and also to welcome you to the Model of Care Forum, and to be part of this amazing journey in healthcare transformation in Saudi Arabia, which is the biggest healthcare transformation across the globe. And in this session, it is actually an amazing session, and we're going to take you on a journey of some kind of discussion with esteemed pioneer expertise in healthcare system from different backgrounds. And it is really a pleasure to have them with us today and to learn from their expertise, and also to share with you their added value discussion. My background, I will start by myself. I'm an emergency physician and also trauma physician, and also part of this journey in healthcare transformation over the past years, with experience in 25 years in healthcare system, and from different sectors, military, civilian, private, and governmental. And it is actually a pleasure to welcome my colleagues here. I will start by Prof. Jason. Prof. Jason actually was a National Clinical Director for Scottish Government for nearly 10 years, overseeing health and social care quality. Honorary Professor at Dundee. He is a Global Advisor on Health Improvement with doctorate MPH from Harvard and extensive public health expertise. Dr. Abdulaziz Twedri. Abdulaziz, he's a health economist and clinical pharmacist, specialized in health economic studies, cost evaluation, and budget impact analysis. And actually, he's working with good and amazing expertise in market access, strategy, optimization, and health technology assessment for innovation solution. In his left, Dr. Nofal Drayan. Dr. Nofal is Executive General Manager at the Ministry of Health, board member of Saudi Red Crescent Authority, is a professor of emergency medicine, and with long experience and passion in leadership and amazing role in model of care in Saudi Arabia. In his left side, Dr. Yasser Al-Ataibi, family medicine consultant background with 13 years experience. Also is a fellow of Institute of Healthcare Improvement and specialized in quality improvement and patient safety. What a quiet panelist from different backgrounds. And these different backgrounds are going to give us big insight about the model of care. Today we're going to talk about actually different aspects of the model of care. In the morning, it was actually quite a journey to talk about model of care history, the start, and what it is currently. And today we're going to talk about different angle for the model of care. We're going to talk about actually the success, and we're going to talk about implementation and strategy, and it will be some kind of interaction between my dear panelist colleagues here. So we will go for some kind of discussion points, and it is my pleasure to start with Dr. Nofal. And maybe we can, based on the discussion here, we can start by what does success mean in the context of model of care?
Thank you, Dr. Saad. I want to start with two of the people on the panel have been my seniors as a medical student. One of them is on my left of me, and one of them is on the far right. So I won't specify so I don't become biased. I want to thank everyone here. I think part of the success of the model of care is the forum we have today, the discussions that are happening on stage, discussions happening behind the scenes, in the exhibition, in the hallways, and so on. To be transparent, the success in model of care has to be multifold. First one is that I think success is going to be when we reach a level where we can make evidence-based decisions based on meaningful data. We still have challenges with data. Measuring outcomes across the whole sector is not an easy thing. Being able to gather information about every diabetic patient screened, every hypertensive patient visiting a primary health clinic, STEMI, stroke, colorectal, breast, and so on. I think that's going to be part of the success when we say that we're really 100% happy with the data we have. I think when we move from measuring numbers and statistical conclusions to true outcome-based measurements, I think that's also going to be one of the big wins we'll have if we have these outcomes available. I think when we start measuring value, truly measuring value about model of care and seeing what we're offering our patients, I think that's going to be one of the huge successes for us. Also coverage. When we're sure that every single beneficiary is reached to properly, and we know that model of care has touched their life or made a difference, also that's going to be one of the success. And also when we looked at cost effectiveness. So currently when we talk about model of care, we haven't started talking about cost effectiveness in a mature, proper manner. We want to. For sure, everyone is doing their best, providing care, but we start talking about the cost effectiveness of the care we're providing. That's also going to be one of the successes I'm looking for. And maybe finally, when we're able to measure and compare what Saudi Arabia is doing to other countries in regards to the outcomes we're measuring and seeing that the interventions that model of care did have these outcomes compared globally and benchmarking that, I think that's going to be our end game, and then we'll start be able to see where we are in regards to the rest of the world. Thank you.
Beautiful. Thank you so much, Dr. Naufal. Maybe I will go to Prof. Jason, and we're going to talk about the same topic from your perspective. How can success be aligned across the stakeholders, different stakeholders, when we're talking about workforce, patients, systems, funding? How are we going to actually deal and look at the success with these stakeholders?
Thank you, and thank you for, excuse me, thank you for having me. There we go. Thank you for having me. Let me just take a moment to thank you for your invitation before I answer your question. It's a real honor to be here. I've been in Saudi Arabia now 3 times in 6 months, and this is the first time you've given me Scottish weather. So it's, even when I came off the aeroplane last night, it was raining, just like in Scotland. So I felt more at home than I have felt ever before. So thank you for having me. Your question has been answered by Saudis throughout the day. I'm not sure I can offer you much more. The answer my colleague gave just now around what success might look like, and you had a previous panel that did exactly the same. In Scotland, in the health system in Scotland, we have been through this exact same challenge. We have a small country, 5.5 million people. We have an integrated health system, one provider, one funder, one system. And we are asked all the time by politicians, by the public, how will we know? What is the outcome? And you can do it at a very high level, or you can do it down in the weeds of the system. So let me start up here. We decided, I'm not telling you to decide, you can decide for yourselves. We decided to adopt a model that came from a man called Tom Nolan at the Institute for Healthcare Improvement. He invented it. And it has swept around the world, and he called it the triple aim. And I'm quite simple. I need simple models to be able to understand them. The triple aim has now become the quadruple aim, so there are 4 now, which I think is helpful. I'll tell you what they are. And they're deceptively simple, but each warrants a conference all of its own. Better care, so that's straightforward. How many MRI scanners will you have? How many people will get dialysis? How will you improve the care of the elderly? So better care. That, I think, is the journey Saudi Arabia's on, the journey Scotland's on. Better health, a different aim. So at the same time as improving the delivery system, you have to also be improving the health of the population. The previous speaker, just on this stage, gave a
very clear blueprint for how that might affect you in sleep, in mental health, in healthy eating. So better care, how your system will design. Better health, how your population will improve. Better value, so what is your unit cost? What does it cost you to take a person who is unwell and make them well? What does it cost you to have a healthy baby delivered? What does it cost you to have no infections in your hospital? How much money are you willing to spend, and spend only once rather than 15 times, to get that better value? And then the fourth, which was added subsequently, is to have a better and healthier workforce. So the workforce feel engaged and want to be part of the system they're working in. So Scotland in 2010, the senior politician, who was the health secretary at the time, my boss, the health minister, she stood up in the parliament and said, Scotland is going to do the triple aim. Now, we hadn't added the workforce piece yet. Subsequently, we've added that. And we published a strategy, the first ever quality strategy. We think the first quality strategy in the world. The Canadians are debating with us whether they had theirs before us. We think ours was the first. And it said, we're going to have better care, better health, better value. And then underneath that, we published the data we were going to use, the measures we were going to use, and we drove that into the system from the top, with the minister, with me as the clinical leader of that mission, and then we started in the bottom. And the place we started, and it's a long story which I won't give you all of, is we decided the thing that aligned every single stakeholder, the patients, the families, the workforce, the funders, the politicians, we needed a subject that would bring everybody together. And the subject we chose was patient safety. So we decided that nobody would argue with trying to make the care safer. So that's where we began. Subsequently, we've done person-centered care, we've done value for money, but the thing we started with was to eradicate infection, stop people falling over, get rid of urinary tract infections, all the harm that the health systems were causing. So we decided to unify around a single subject. Now, it was complex and complicated. It was the whole system, primary care, dentistry, hospitals, but we decided to do it together. And for Scotland, that started our real transformation.
Excellent. I'm going to move to Dr. Abdulaziz, and we'll take the discussion now to the different perspective related to strategies for implementation for the model of care. From your perspective and your opinion, Dr. Abdulaziz, what are the critical enablers for model of care implementation to make it actually successful?
Thank you, Dr. Saad. I think, in my opinion, in any implementation of a new concept to an area where it's never been implemented before and people are not familiar, there is a lots of challenges in terms of first implementing a change where people will start to resist in that. So in my belief, there is a need for 5 main components for the implementation, and I believe some of them is already exist in the current model of care. For example, when you want to implement any changes, there is a need for a strong leadership and a good governance about it. And I think the current model of care were designed carefully, led by the right people, and I think it's gonna move forward, inshallah. The second thing which I think maybe we need to implement more is the stakeholder engagements. When I meant by stakeholders, not the main player in the system, but also the frontliners, where they need to believe in the model of care, they need to understand what is the value of model of care, and how this change is necessary to be done, and how that in return will gonna change the life of people. Probably one of the things that also we need to think about in the model of care, and I think that's one of the challenges, is the workforce capacity. Within the model of care, there is a big promises about the care gonna be delivered, the screening program that everyone will receive. However, is the current capacity will be able to do that or no? Setting a wise objectives, reasonable objectives that can be delivered in a short term that will make us having like quick wins will be probably the best step to do, at least at the beginning, making sure people will start to believe in the model of care, feeling the success on that. Nevertheless, never forget about the resources allocation and the funding required for implementing the model of care. Yes, the model of care in principle is a very good approach. However, we have competing priorities that will require funding. So being reasonable about what to fund and what to start with, implementing the whole model of care at once might be good, but sometimes might not be feasible due to it will drive resources from current services that we don't want to be interrupted, at least at the time being, until we achieve a point where the model of care will reach its target, inshallah.
Thank you, Dr. Abdelaziz. I will move forward to Dr. Yasser. Dr. Yasser, from your opinion, how can a process be standardized? Because as you know, standardization is very important in the model of care. How we can standardize the process across different healthcare settings while ensuring adaptability?
Thank you, Dr. Saad. First of all, have you noticed Dr. Naufel's attempt to appear younger than he is at the beginning of the session? So, Dr. Naufel, you don't have any proof that we are your senior. So thank you, Dr. Saad, for the very important question. Now, if you are going to implement evidence-based programs, you need standardization. And research shows that the more standardized interventions that you have, the better adherence to it. But it's like a coin. You cannot have standardization without what we call adaptability. There's a common pitfall in implementation science that people do not address adaptability from the beginning of the implementation. It's like an afterthought. They come up with these evidence-based programs or standards, evidence-based standards, and they push it throughout the system, and they don't seem to work. And then they start to adapt. And there was a very relevant example this morning from, I think was it from Brigham and Women's Hospital, in which that it was mentioned that different radiology departments have different protocols. And I could argue also, if you come in at evening, you'll also have another different protocol. And if you come in at the weekend, you're going to have different protocols. Because different times of the day, different settings have different requirements. And this is why we call for contextualization. So for you to implement an evidence-based program, you need to standardize and you need to plan for adaptability. Now, there are a lot of frameworks for adaptability that can help teams to plan for adaptability at the beginning. One of them is Aaron's dynamic adaptability process, but this has to be at the beginning of the implementation. And you need to plan what components are you going to adapt, who is allowed to do the adaptation, on which level do you do the adaptation? Is it macro, meso, or micro? And what components can you adapt? Can you delete certain elements or certain standards? What are the core components that nobody should touch? Can you add? Can you delete? Can you lengthen? Can you shorten? There are a lot of case studies and good examples of how systems have implemented evidence-based programs which are similar to the model of care, and at the same time, they were very keen on doing the adaptation. One example that stands out was from Kurdistan. So in Kurdistan, they wanted to implement mental health care program, an evidence-based mental health care program that was taken from the US, and they wanted to implement it for violence and torture victims. But they were smart, so they planned at the beginning that we'll take the evidence-based package, but we'll do some adaptation at the beginning. The package required psychotherapists. In their villages, they didn't have psychotherapists, so they trained lay healthcare providers. The change package required mental health care clinics. They don't have mental health care clinics, so they substituted that by the general clinics in the villages. The forms that they used, the assessment forms that they used, it required translation. It required some changes to fit the culture. They even added some pictures, so they removed the Likert scale, and they added pictures so that the people in the village can answer the questions very clearly. So all of that helped them to implement and standardize, and at the same time ensure that it fits. We need to remember, for evidence-based program and implementation science, not all size, there's no one size that fits all.
Thank you so much. I think I will go back to Prof. Jason. Implementation always going parallel to measurement, and to have proper measurement of that success, you need to have meaningful metrics. And that to evaluate the effectiveness of the model of care. What do you think about that?
So I wish it were simple. It isn't. Let me maybe illustrate it with a story from Scotland that fits Yasser's example and then leads into measurement. So, like most of the world, we were trying to implement the surgical checklist. And we were trying to do it at the same time, actually, as Canada were implementing the surgical checklist. We took 3 years to implement the surgical checklist, 3 years. And we reduced surgical mortality by nearly 20%. So a fifth. We reduced our surgical mortality by a fifth. But we implemented it in the way that Yasser has just described, where you allow nobody not to do the checklist, but it turns out that if you're doing a cesarean section, your checklist might be a little bit different from somebody having a kidney transplant. You would have some similarities in the checklist, but the checklist would look slightly different. In the cesarean section, you need 2 heart rates. You have a baby and a mother. In the kidney transplant, you only have 1. So you get the idea. So you need to be able to adapt across them. The Canadians sent the surgical checklist to every surgeon in the country and said, please implement on Monday. That was their implementation method. Please implement on Monday. And nobody did it. It's not really a big surprise. Surgeons don't do as they're told. I am one. I'm allowed to say that. And they published an article that said the surgical checklist didn't work. That's not true. What didn't work was their implementation method. If you implement properly, with people engaged in the process, with workforce, patients, families in the center of the design, and you allow that adaptation. Nobody said you don't get to do the check. Everybody had to do the checklist, but you're allowed to adapt the checklist as you go. And there is science that we don't naturally know just because we're dentists or doctors or nurses. There is a science you can learn. And at the heart of that science is measurement. But it's more complex, unfortunately, than we pretend. People are looking for the dashboard, the magic dashboard that will prove their model of care, the Scottish model of care, the Saudi model of care it doesn't exist. Okay. The secret dashboard doesn't exist. Otherwise, we would all have it. What you need is a cascading set of dashboards all the way down to the front line in the family physician practice, the physiotherapist, the dentist, the family practice, all the way up to the transplantation people, the finances, the how many clusters you're going to have. So you need measurement at each of those levels. And you can't pretend that the doctor, nurse, small team on the ground will be able to react to the big finance numbers, because that's not going to happen. So the neatest way of dividing it quickly in my world is you need microsystem measurement to drive change. That might be in your own system. It might be infection rates. It might be time to next appointment. It might be access. You need mesosystem, middle layer. So that might be system infection rates. It might be how long does it take to have a hip replacement done across cluster X or cluster Y. And then you can begin to compare across the mesosystems. And then at the macro system, in my world at a country level, probably here at a country level, you have a dashboard that tells you how the whole system is performing. What is the infection rate across the whole system? What is the mortality rate across the whole system? What is the public health metrics around the whole system? But you can't just have it here, because that's not going to be meaningful for the microsystem. You have to have it at each of those layers. So I'm afraid the measurement challenge is even more complicated than we hoped it would be, because you've got to create measurement in each of those systems. And as I travel around Saudi a little and get to know your system a little, I see really good examples at each of those levels. No country in the world has solved all of that, but you are on your way to solving each of those sections.
Thank you so much. I will go back to Dr. Yasser. From your opinion, Dr. Yasser, how can tools and frameworks ensure continuous monitoring and improvement?
So it's a two-part question. So part of it is monitoring,
and
part
improvement.
of it is improvement.
Yeah.
So I'd like to build up on what Jason mentioned. You need to have a comprehensive monitoring plan. A common pitfall, again, when implementing evidence-based programs is that we're always one-dimensional in doing the measurement. If you're going to measure implementation, we're talking about implementation, we're not talking yet about improvement. Implementation, it has to be multidimensional. You need to measure the implementation part. You need to measure the system part, and you need to measure the population part. And each one of these has to be cascaded to the different levels, macro, micro, and meso system. It has to be linked also to the individual providers. And you need to, once you have identified these measures need to be evidence-based, they need to be standardized, they need to be agreed upon by the stakeholders, they need to be relevant, meaningful, standardized, how you collect these measures, because you're going to compare different clusters, how they are implementing this evidence-based program. And they have to be transparent, especially to the stakeholders, because it's not going to be very helpful if the stakeholders do not know how they are performing in comparison to others. How am I implementing, let's say, the chronic disease model in comparison between cluster 1 and 2 and 3? And even you go down to the unit or to the individual level. So there has to be a mechanism also to close the feedback loop regarding the monitoring. Now, there's also new methods for monitoring. And there's a big push now from the NIH in the US on what we call a mixed method monitoring. So there's a quantitative part, data, and there's also a qualitative part, in which that you go down, you interview people, you interview the leadership, you interview the staff. How do you think the model of care is working? Is it working? What do we need to do? So you do interview, audits. There are even some programs that they do some video recordings so that they see how things are happening actually on the ground. And you compare that with the data. That provides a comprehensive or more holistic way of monitoring implementation of evidence-based programs. Now, going to the improvement part. Now, myself, Jason, we're from an improvement background, so we're more dynamic. Now, you need to understand that implementation science is different from improvement science. There are similarities, but there are differences. So the implementation science is more deductive. It's more rigid. This is the evidence-based package. You need to implement it. There are some leeway for adaptability. From our approach in improvement science, we're more inductive, we're more flexible, and we always close the learning loop. So I think the way forward should be, there should be some cross-fertilization between implementation science and improvement science. I've seen an example. Dr. Wayne mentioned that when they implemented some of the lifestyle programs, they included PDCA cycles. And I think this is the frontier, that if you're going to implement model of care, evidence-based programs, you need to be flexible and bring in improvement science. And in the US, the Center for Cancer Prevention and Control, in their latest cycle, in the 2024 cycle, they established a task force to implement improvement science with implementation science. And they have 17 programs. One example was in New York, in which that they wanted to implement the HPV vaccine and for underprivileged communities. And they used PDCA cycles. So they came up with a change package that all of the health centers need to implement it. And they gave them some flexibility. I implement at least 3 learning cycles and modify as you go. And improvement and uptake of the screening program significantly increased. So there has to be some cross-fertilization, especially during the implementation phase. Use some of the tools that are tried and tested, like the IHI model for improvement. It works. The IHI collaborative methodology. There's a big need for healthcare teams. If we are all going to implement the same change package, different hospitals, bring us together, let us learn from each other. There's a big need for us to discuss what worked in your setting, what didn't work in my setting, and how can we work together to implement the change package. Now, in our setting, in the Ministry of Defense, we've been doing improvement collaboratives probably for the past 5 years now. We have around 26 improvement collaboratives. This is our way of implementing evidence-based interventions. We use collaboratives and improvement science. It's successful, but I think there's also, we can learn more from implementation science. Currently, there's a small group in the Ministry of Defense that are trying to come up with a conceptual framework that cross-fertilizes implementation science and improvement science. Hopefully by next year, we'll have something that's publishable. And if anybody is interested to join us, we're a small group that we're trying to come up with a conceptual framework. If you're interested to pitch in, contact me.
Excellent. So from the experience which you mentioned about the improvement and the monitoring, what was the #1 challenge facing improvement and facing monitoring?
So for improvement, so the #1 challenge for improvement is having that platform for the teams to come and talk with each other. The second is standardizing the tools for improvement. A lot of the teams, so you give them the change package, you tell them implement it, but they're not very much trained in using these tools. So building capability within the system for improvement is vital, so that they become more inductive and learn and improve.
Thank you so much, Dr. Yasser. We're going to move for Dr. Abdulaziz. We'll talk about sustainability of success, but that need to be incentivized. And this is part of the equation, which is very important. We need to keep an eye when we are talking about success in model of care by incentivizing people. So from your perspective, how can metrics and outcome be used to drive accountability and incentivize quality improvement?
Thank you, Dr. Saad. Probably I need to first just to clarify one point. Incentives not always mean money. People, when they hear the word incentives, means that they will be paid for. However, the incentives, I think it can come in many forms. One of them is recognition, one of them is the feeling of achievement, etc. So I think having the measurements by itself gonna build the incentives for that, because usually there is an old saying, I can't remember who say it, but something that you don't measure, you cannot improve. And you have to choose wisely what is the things that you want to measure, because you know that it will be affected after your measurements. People will be incentivized in order to achieve a better rank, in order to feel the improvement, in order to feel that they are progressing over time. So whenever we choose the metrics, we have to choose it wisely, to choose the things that we feel it can be improved. Otherwise, people will be feeling like they don't achieve any success, and I think that's one of the things. The other things for also the measurements and the metrics is to consider it as a good tool for you to make a decision making in the future, meaning that if you achieve a certain improvement in a program or so, do you want to continue with it? Do you want to replace it with something else? Do you want to build on it and take it to the next level? And having these kind of decisions that is based on evidence that you gather from the measurements and the metrics, I think that's also some sort of incentives for people, knowing that if we achieve this, we're gonna move to the next stage as well. Sometimes you don't have to look at the incentives from the positive side, look at it also from the negative side. If you put metrics, people will start to feel that they are accountable. They have to achieve something, otherwise it's gonna be considered as a failure for them. And this is like in a back reverse psychology, it's an incentive for people, so they want to look in a good position when they carry on with a program. And I think that's, in my opinion, is the major things, is to choose the right metrics that you know people can affect it, can improve it, and can result in overall success of the model of care.
Thank you so much. We'll say it. The last point from my end will be with the senior, handsome Dr. Naufal. From your opinion, Dr. Naufal, and experience with model of care, what mechanisms can ensure long-term adherence to the model of care principles?
And maybe I'll come back to what Dr. Yasser and the others talked about, is continuous improvement and continuous monitoring in a proper way. I think embedding model of care into the framework of the system. So model of care is embedded within MOH 2.0, which we've already finalized. I think 3.0 and going forward, model of care has to be part of the framework, has to be part of the governance, because if it's distant from there, it will be forgotten, like a lot of other projects we've started before. The other thing is that something we've never talked about clearly is, where is model of care from continuous medical education? Where is model of care from schools of pharmacy, nursing, medical schools? When we start having residents go through model of care and their training, talking about it, most of the people who talk about model of care are people who are involved, either directly or indirectly through scientific committees or meetings and so on. But once we go to the practitioners, not a lot of them know a lot about model of care. So I think if we go to that soft side, changing the culture with the monitoring and in regulation, I think that's the way to go forward. Thank you.
Excellent point what you mentioned about change the culture and the long term. What do you think, how are we going to invest more in change the culture in that perspective?
So we put a lot of effort into talking about model of care to each other. So me and Dr. Saad and a lot of other people in this room have continuous meetings throughout the year about model of care. We talk about it so much and so on, but we haven't really invested on going to the micro level in regards to asking them how they feel about it, how to change model of care to fit their practice, telling them what we're doing about model of care. So we see the dashboards and the numbers, and we talk about them together, and we publish papers. But do we go back to these people and tell them, listen, the intervention you did has this impact on model of care and so on? We haven't made it our daily life to talk about model of care. So we talk about it formally, but informally, it's not always on the top of our mind. Any people as old as Dr. Saad and Dr. Yasser will remember when we didn't use seat belts in Saudi Arabia. When we didn't use seat belts, قبل ما يكون في مخالفات على حزام الأمان. I remember that wearing a seat belt in Saudi wasn't, it wasn't fashionable, right? Today, you rarely see people who don't buckle up, right? Because there was governance for it, there were incentives, which were financial and non-financial, but it became our daily culture. So I think we have to shift model of care from within forums and within conferences and committees and discussions to our daily talk, our daily lingo, our students, the people we work with. Everyone has to have model care embedded within their system. So it has to be a cause, it has to be a way of life rather than a project that we're trying to implement.
Thank you. I think as a conclusion, I will start to ask each one of the panelists about the future for implementation of model of care in Saudi Arabia. How do you look at this future based on the discussion here, based on the discussion this morning, and from your expertise? I will start by Prof. Jason.
So I think you are an inspiration to the world. I genuinely think you at the beginning in your introduction said this is the largest health reform globally, and you said it as if it were nothing. I mean, just take a moment to understand what that is. You are the biggest active health reform globally. That's enormous. And you have an enormous responsibility to the population of Saudi Arabia, but I would also argue that you have an enormous responsibility to the world. Because the reason a number of international guests are here, don't kid yourself that we're here for you. We're here for us. We're here to learn, as well as to offer maybe a little bit of experience from elsewhere. But I think Saudi Arabia's implementation of the model of care, your payer system, your cluster model, it is potentially an example for the rest of the world. And you will make mistakes. It will not be smooth. It will be bumpy. But there are things in there that I think you will teach us. And perhaps there are also things the world can teach you. Most of the problems in healthcare have been solved in at least one place. They haven't been solved everywhere, and nobody has solved them all. But if you ask me where the best elder care in the world is, I can tell you. If you want to know where the best children's hospital in the world is, I can tell you. So there are pieces everywhere. And Saudi Arabia has this enormous opportunity and responsibility to bring all of that together, perhaps in one country, that we will be able to watch from outside and see develop.
Thank you, Dr. Abdulaziz.
Thank you, Jason. For me, I think we have a very great opportunity to success with the model of care. We are in the middle of the transformation. We are transforming MOH into different entities, and keeping in mind that we have also a young generation, and the model of care is basically more focused on how different services, focusing on preventions, decrease the burden of diseases. And I think the current demographics of Saudi Arabia, the current transformation of the system, and the current resources within the healthcare system, shifting resources from one, I would say, non-cost-effective areas to more cost-effective areas. All of these are factors that can participate in the success of model of care. Model of care, it's a dream of everyone, and we have the tools for it, but I think what we need is that everyone should believe in it, not only as Dr. Naufal mentioned, not only the people who are involved in the model of care, but everyone involved in the healthcare system as well.
Thank you, Dr. Naufal.
Thank you, Dr. Saad. So this is my second year in model of care. Before I started, I didn't have that depth of knowledge into model of care. So I think one of the most important things I've done in my life is working in model of care. The start, so in Ibn it's going to be successful and sustainable. And so the center of government understands the importance, and they taught us the importance. And model of care is mentioned in royal decrees by name. So model of care is mentioned by name and royal implemented. So that tells us the importance of us. So the vision was given to us. We have to follow that. So if the government sees the importance and supports us with that, the entities talk together very well. The momentum that I received when I started was already going forward. We're seeing the results of model of care now. This has started, a couple of years back. So the momentum is there. The people are there. The intentions are good, and there's no way to turn back. So we've already burned the ships. So there's only one way to go. It's going forward. People are enjoying working in model of care. We see people, challenging each other to get better results, people wanting to see how they achieved this month and the month after and so on. The leadership in the healthcare sector have invested a lot into it. His Excellency, the Minister, the Vice Minister, the Assistant Minister, Mr. Nasser Al-Hagbani, CNHI, everyone is focused on model of care. So I think, bidnillah, it's on the right track. We've built a lot. We still have a lot to go forward. But it's bright and it's amazing.
Thank you so much. Dr. Yasser.
So the only future I can foresee is Nawfal's future. It's going to be a busy future with the model of care. I'm hopeful and optimistic. And my advice for Nawfal is try revisiting your implementation plan. Try incorporating more of improvement science, inductive learning, listen to the providers, and see how you can contextualize and adapt the model of care so that it can be, it reaches to the bedside.
Thank you. It looks like we conclude here at the end of the session by some important messages. Successful implementation of model of care is going in the right direction with bright future, and that need actually the strong leadership to bring all the enablers together, and at the same time we need that effective metrics to monitor the quality and to standardize the process and to incentivize the quality improvement and the quality work. And by saying this, I want to thank all my colleagues, the panelists, for your time, for your amazing input, and actually more thanks and appreciation for all the audience. Thank you so much.
Thank you very much, Dr. Saad Asiri, and distinguished panelists. We appreciate your insights and your input. Now, we are coming on a break, but we would like to borrow some time from your break, and we'll give it back to you at the end of the day so we can catch up on time. 10 minutes, enough time to pray and stretch out. We will be back at 38 of the hour.
announcement إنه يحضروا حالهم to take their seats.
Okay.
Yeah. Your mic is on.
Ladies and gentlemen, if you would make your way to the hall so we can start the next panel, we would appreciate it. Thank you. Ladies and gentlemen, welcome back. Home stretch. We are almost at the end of the segments for the day. It has been rich and full of excellent insights from both our national and international speakers. As we go into our last segment, we know that digital health technologies are the future, but they're no longer the distant future. They are reshaping how care is delivered and coordinated today. Next, we will explore how AI and big data are transforming healthcare by enabling personalized care at scale. We will learn how these technologies can bridge the gap between individual patient needs and population-level healthcare delivery. The segment will highlight successes, challenges, and lessons learned in leveraging AI and big data to drive personalized, value-based care. For this, we have a distinguished panel of experts who bring diverse perspectives and real-world use cases into how these innovations are being implemented. This engaging discussion will be moderated by a leader in healthcare innovation and technology as the Chief Innovation Officer at Open Medical. Please join me in welcoming the panelists moderated by Dr. Piyush Mahapatra.
Good afternoon, everybody. So I'd just like to thank the organisers for this opportunity and for my fellow panellists for us to a deep dive into something, well, it's going to be hopefully a very interesting topic. I think Dr. Tariq sort of mentioned earlier around the need to think globally, but implement and act locally. And as the pace of change of new technology really takes flight, and emerging technologies such as AI have come on the scene, it's be really exciting to now do a deep dive into how we can use this to enable the model of care and how we can really look at delivering personalized care to the individual. So without much further ado, I'm going to dive right in. So Dr. Shabab, as the Secretary General of the Council of Health Insurance, I'm sure many of our audience members are really keen to understand, what does personalized care at scale mean for you, and why is it important to the model of care?
Thank you, Piyush. It's given me a great pleasure to be with you here today, and I'd like to congratulate Model of Care of Ministry of Health and also Holdco for arranging this important event to discuss the most important challenges that we are facing in model of care by bringing local expert and international expert, and I hope everybody in the audience will enjoy and will benefit from this event. I think as a physician, this is the wish or the aim that we look for from the day we enter medical school. How can we personalize care? And I think it's the dream of 21st century. And it's really an normal evolution of healthcare. If you remember, if you are old enough to remember, in the late 80s, early 90s, we came with evidence-based medicine. Then it evolved around patient centricities. And now we are evolving more to be individualized centric. And from the name of it, it's personalized care. It's really a medicine special for you. And it's really dependent on your genetic predisposition, your race, your lifestyle background, your kind of environment background. And any practitioner in the audience will know very well, sometimes we apply the best evidence even though it doesn't match our target population. Either the study or the literature was around different race, but we use it because it's the best evidence. So I think with the evolution now, with the kind of evolving the whole ecosystem around patient centricity, and you can imagine, we start in our hospitals over the last 2 decades saying we are beneficiary or patient-centric, and we start to have multidisciplinary approach. And now the model of care is evolving around us, not only from individual perspective, from population perspective. Now each cluster are in charge of 1 million population or 1.5 million. They will provide them with a comprehensive care from primary care to tertiary care. This will help to provide an integral care and a unified model of care to the whole population. And this will help us to track our beneficiaries, know their genetic predispositioning, know their response to treatment. And with the evolution of data around that, we'll be able to make a very precise decision for treating patient, not by using one size fits all, by using specific intervention, either from screening point of view or from treatment point of view, that it is geared toward your genetic predisposition, your race background, your lifestyle, and it's a journey. It's not an easy, but with the evolution of AI around the globe and with the breakthrough that we see every day, I'm very optimistic that we will evolve and go toward precise medical care. Vision 2030 has really given us the empowerment, either from raising the bar or from raising the target, having a vibrant societies and ambitious nation by digitalization to give us the capability toward that direction. Thank you.
Fantastic. Well, thank you very much. And I guess just to follow on that, is there a linkage with outcomes around personalization? So if you deliver personalized care how do you understand the benefits and the outcome benchmarking when every individual has a varied treatment plan?
So that's actually the key principle, how we link rendering care and the outcome to the value that we are looking for. So if we adopt the value-based healthcare principle, where we provide care to our population, try to measure the outcome either from experience or from outcome point of view or from efficiency point of view, we'll be able to improve. However, this will help us to understand the peculiarity of each individual and will help us to collect more data about the best treatment for each group of people based on their genetic background. So yes, the answer today, with the capability of digitalization and the interconnectivity between all providers, we'll be able to track that faster and we'll be able to measure outcome with more precision. That will help us to mature the precision kind of approach to our beneficiaries faster.
Fantastic. Thank you very much. And then I think speaking as a chief exec of a well-known center such as Houston Methodist, Kathy, what's been your experience on implementing some of these emerging technologies? And have you had any specific areas of challenge, or have you learned any lessons along the way that could be useful for our audience?
Thank you, Pish. Yes, we have. So our organization is a little over 100 years old, and as we were looking at our second century and what are the priorities for our second century, we really boiled them down to in just a few words: unparalleled service, quality, patient service, and innovation. And when we think about innovation as being a core element of that, we really had to think about how we would structure that as an organization. And so for us, one of the ways that we were able to really tie things together is that our CEO of our large academic medical center is also our Chief Innovation Officer. And we did that very purposefully because we were not embarking on innovation just for innovation's sake. There's lots of good reasons to do that, but for us, it was really how can we translate anything we're doing from an innovation perspective into a return on that investment, and keeping, in our view of keeping the patient at the center of everything we do, improving patient care. And so a few real-time examples of that, because we're using AI in predictive analytics of patients who are already an inpatient. When can we expect for them to be discharged? When can we expect? Where do we expect them to go? Are they going to need to go to rehab? Are they going to need to go into home care? So there's a lot that we're doing from a data perspective. But I think one of the biggest pieces, in addition to having leadership at senior levels, knowing what you're trying to accomplish, tying any of these innovations back to that strategy and back to that ROI. Because otherwise, if you just take your existing processes and you put innovation on top of them, you just have more expensive processes than you did before you started. So for us, from an ROI perspective, that's very key. We, on an annual basis, have several hundred different technologies or innovations that come our way. We evaluate, we evaluate those, we sort those out based on strategy. Then we evaluate them based on more specific around if that technology is ready for where we are and if we're really ready for that technology. So looking at all of those. And then what are those measurable outcomes going to be? We do that all before we even get started, because otherwise our goal is to succeed fast, fail fast. I wouldn't say fast, I think, is a relative term, but we have goals. And so then around that, I would say the other biggest piece, or one of the biggest challenges we've had, has also really been around readiness and ensuring that we're bringing everyone along the way. One of the early ones that we did, and actually today it's a success, but it was around looking at reducing our cost of our operating rooms, being more efficient, but also really from a supply cost perspective. And so we put cameras in all of our operating rooms. If you would like to unite all of your physicians against you, go put all cameras in all of your operating rooms. It was really unifying for our physicians. And it was a great example of where we did not do enough work around change and change management, getting all the stakeholders to the table. Eventually, we were able to implement that. We were able to take some of those gains. And again, improving the quality of care for that patient in that the cases are shorter, the turnaround time is less, physician burnout is less. We've had a cascade of benefits as a result of that. That's just one easy one.
Fantastic. Yeah, absolutely. I think, you know, as a Chief Innovation Officer myself and a practicing clinician, I think that linkage between the operating capability of the organization and the innovation arm being tight, I think is really critical. Otherwise, as I said, innovation just sits in a silo and someone does this next big shiny AI project that never really translates into real frontline clinical benefit. You lost me a little bit when you put cameras in the OR, so I'm an orthopedic surgeon, so obviously that's something that, yeah, absolutely would put me off. So again, you talked a little bit around return on investment, and I'd like to ask Dr. Attila, you know, particularly with your academic background, hopefully we don't need to use your disaster management hat, but more your digital health one. So how do you measure the return on investment on some of these emerging technologies? Again, when there's so many unknown unknowns, how do you set up a framework? How do you set up capability to do that?
Yeah, that's a great question. I think that part is still many organizations are grappling with in terms of the return on investment, in terms of the money that you're already spending on that. I think the question most organizations are thinking about also is, when do you turn it off? For example, if you put in so much money, how do you know that that technology is actually working? So there's a couple of organizations that have actually done that recently, where they're like, okay, this isn't working, this isn't addressing the mission. And back to what Kathy was saying, we've seen this happen where a technology, a particular AI technology was implemented, a lot of money was put into it, and the change management piece wasn't perfected, and the staff didn't buy into it. And one of them was actually robotic technology, and basically we had to cancel the project. So I think that understanding about failing fast and actually thinking about how much money you're putting into these technologies as it's changing so fast, it becomes really important that it's aligned to your mission. And that mission is going to drive exactly what technologies you're going to use, because what we're going to see now is just this tsunami of technologies that's going to be coming everyone's way every day, all the time, and to be able to choose those technologies is really important. I think the other aspect in terms of ROI that a lot of organizations are not considering is, do you build in-house? Because that is a strategy that many organizations are grappling with. Do we build this in-house, or do we buy off the shelf? And we're encouraging people to buy off the shelf. Healthcare organizations need to go back to mission. If you're thinking about personalized care and you're thinking about what you're doing, do what you do best, which is healthcare. And the technology piece is something that can be integrated into your organization as something that's already fully developed. Many organizations have now also, when you're talking about ROI, have spent an enormous amount of money and have gotten nowhere. Back to that, well, what's the return on objective, or how do you measure it, I think is the most important. What have you done? Oh, you spent 16 months developing something that wasn't implemented. How much money did that cost? And then you get fatigue in the organization, and then sometimes the product that's developed just doesn't get the uptake. So I think those are some important considerations, is to really consider the proven technologies that are out there, partner with a co-creation of that technology, and maybe consider not doing it in-house if that's not your skill set.
Yeah, I think absolutely. There is an element of focus, I think, needed by every organization. With the trajectory of these technologies, where do you see that going? I mean, obviously there's been very topical with AI in the news about something that I think in technology circles has been well known, that open source large language models seem to be performing nearly as well as those large investments. So sort of as a question, is there an argument for waiting? before you deploy, or seeing where the technology goes before you utilize it, or do you think we should be jumping in now?
Well, I think there are some organizations that, well, let's wait and see. I encourage everyone to get in there right now, because that ship is sailing and it's going to sail really, really quick. And it is changing so radically quickly. It's really almost, it's like drinking from a fire hose, you know, that expression. It's happening that fast. You do need to be involved, immersed in it, and look at and evaluate the technology. Have a framework, have your entire organization having that AI governance council, for example, that assists you to be able to make some of these decisions as these things are coming so quickly, especially when it comes to evaluate. And stepping ahead of that, I think, is a little bit difficult, but I think it's one of those technologies that's going to absolutely impact everybody. And it's going to impact, realistically, every single service line that we have. And when you're talking about personalized medicine in terms of the patients, it's going to affect absolutely everything that they do. When you think about this from the perspective of Dr. Peter Diamandis talked about this recently on one of his functional medicine podcasts. He said that very shortly, it will almost be malpractice if you don't have a co-pilot with you. And so think about all the different specialties and all the different areas that will impact. All providers, all healthcare organizations have to be immersed in AI and have a knowledge base built up so that as these things are coming, which I think you might have a question later about workforce, I think that we're still ill-prepared for mass adoption of AI as it relates to our healthcare workforce.
Fantastic. And so far we've heard quite a lot about the technology and around the implementation, but less around, what problems are we actually solving? So, Dr. Mohamed, as sort of General Director of Corporate Planning and Regulatory Affairs at the National Guard, could you tell us a little bit about some problems that AI is actually solving?
Assalamu alaikum jami'an. Thank you for the opportunity to be here. We were actually privileged in National Guard and the whole healthcare sector in Saudi Arabia with the amount of investments in leadership, workforce, and even technology. Also in National Guard, we have the privilege of caring of the beneficiary throughout the spectrum, primary, secondary, tertiary, and even advanced care. From checking blood pressure at primary care to having gene editing therapy for thalassemia and sickle cell disease. For this whole system, you need to create capacity, you create efficiency to able to sustain this innovation. I will tell you one example that we have noticed at a regional level in Riyadh. So we are, during our quality review, we are reviewing the diabetic care, the spectrum. We have known that for the 8 diabetic patients that you need annual retinal screening. Actually, the demand and supply in our outpatient care does not meet the required. So we have almost 2, 3 years or 4 years even for annual retinal screening waiting list. So what we usually do at these stages, we deploy a bunch of ophthalmologists at primary care, do this function, and do it every 2, 3 years. Then our ophthalmologists, they try to think it differently. So why not deploy the software that can capture the retina at the primary care center, send it to the, get processed by AI, have a decision, and because of narrow margin of error, we still have ophthalmologists to review it, but instead of ophthalmologist reviewing 20 patients a day, he can review 200 patients a day. So we're able to, over the last 2 years, to screen almost 30,000 patients a year. With the referral to the ophthalmologist being only 30%. That's creating almost 18,000 appointment ophthalmology in Riyadh only. So thinking about the opportunity that you have, it's AI developed that can create for you as efficiency, create more capacity to clinician to work, I think the opportunity is massive.
Perfect. So again, I think a sort of common theme emerging is around trying to address the AI use case to something that solves a real problem, where there's potentially a demand-capacity mismatch. But also, when you're looking at things like the ROI, is stopping. What are you going to stop? So I think there's too much where the AI becomes an additional technology cost or a cost pressure, and actually it's important to say, what are you going to stop? And actually, this is where the model of care comes in, because it's the perfect opportunity to sort of execute on that vision. So I think, as I said, it's a really good time to think about implementing some of these emerging technologies. So a little bit more of an open question, I guess. What do the panel feel about what are the enablers around and barriers to implementing some of these technologies, whether that be sort of strategic national level or even provider level? What's helping and what's getting in the way?
I think one of the challenges that we are seeing more and more of is trust. Trust in the AI, in terms of how good is good enough. Some of the research that we're doing right now is around quality. What is the quality of the output? And there's a big difference if you're looking at the use of AI in terms of administrative tasks and you have error in there. That's different in terms of if you're looking at SOAP notes, for example, and you're taking those and transcribing that and providing patients with medical advice based on the AI, and then the physician actually will look at that and then send it out after they reviewed it. And that's one aspect. But when you're looking at the clinical side, which is a lot more complicated in terms of how you would use AI, how good is good enough? And that trust in AI and being able to get physicians on board and clinical providers right from the get-go in terms of that co-creation process, I think is imperative. If you bring in a technology and you did not get that first buy-in, you're going to make it a lot more difficult in terms of the organization, because as you start to bring in different types of AI projects, agentic agents, things like that, it's going to require that organization knows that its administration, its leadership are thinking about the trust factor, and that's a big issue.
I will speak from regulatory point of view. I think we need to be, as a regulator, faster than what we are in terms of allowing AI to move on by providing first the sandbox or the chances for experimenting things that we can monitor and we can validate, and then we can approve as a medical regulator or healthcare regulators, including helping our researcher to do the right research and to validate these kind of AI and innovation that will help the patient rather than hurting him. So I think all the world are now suffering that the AI is moving faster than our regulatory system. So this is the challenge, I think, that we need really to look at carefully. And in the kingdom, each sector, for example, the financial sector, the health sector, the digital sector, they are creating those kind of what we call it sandbox, where we can foster those kind of innovation, learn from it, try to make it very validated. It's really addressing patient needs, cost effective. And then I think we will be able to, however, I think the wishes and the aims and the hopes is more than what is the current speed. I hope this will move faster in the upcoming years, inshallah.
I would just add to that. I think that I think it's a couple of things. I think it's trust, as Dr. Attila said. I think it's also human nature. I think that we are resistant as a people to change. And I think about a couple of things that ended up being very successful, but ambient listening, our physicians are using ambient listening in the clinics. It has really changed, it's changed their lives, to be honest with you, that they're able to have a lot, the notes are better. From a personalization perspective, the patient feels that the physician is not looking, kind of listening while they're typing, hopefully getting all of that. They're getting all of it. The notes are candidly a little bit better. The reports are better. They're better organized. They sign off on them. The physicians have more time. The patient gets a better report. So from a model of care, one where we've been able to change model of care, how care is delivered, improve the patient experience, as well as improve the caregiver experience. We've also seen that in nursing, where we're using remote nurses, virtual nursing, in order to do a lot of the registration process, a lot of the discharge planning, and allowing our bedside nurses to operate at a much higher level than they were whenever they were also performing those activities. But I think there's a fear factor whenever you say, we're going to take something away from your day, and that it creates fear and lack of trust. But we've actually been able to change our nursing ratios and bring them down, which was, challenging and a little controversial, but we did it. And so I think that it's those things where you're able to, get the trust, get them implemented, work with the willing, and then I think one of the parts that we maybe haven't said enough about is replicability. And then how do you then take those and move those, in our case, throughout a system, or as we're working with other partners around the globe, throughout other organizations. So I think that replicability is also a really key to that.
Yeah, one other thing I wanted to mention is, and I haven't heard it talked about too much yet at the forum yet, is the whole aspect of scaling up our workforce in terms of AI education. One of the things I always ask, whatever type of workshop I'm doing, or even of my students, is how many people are actually using ChatGPT. And students don't know how to actually answer that question. It's like, oh, if I say something, what's the professor going to say? I asked them, and even now, it's about 60 to 70% of the class are using ChatGPT. Why isn't it 100%? And you go to, and if you go now to the health sector and you ask people how many people are using ChatGPT, and I'm not just talking about clinicians or administrators, you'll find that the numbers are not there. They're maybe about half of the people or even less, particularly in the region, are using ChatGPT. Now that's just ChatGPT. And if you're thinking about the mass adoption that's going to be happening of AI, we are just needing to get now ahead of the curve in terms of AI education. And that can take the shape of a number of different forms in terms of either, workshops, but the academic institutions, I think, is an opportunity for the Kingdom to partner with to accelerate that AI education. For example, we have a paper forthcoming in JAMA. It was a Delphi study that we did globally about AI education in medicine, in the medical schools. So we developed now the competencies for what is the AI competencies required in medical school. Now, of course, this needs to transcend into public health and nursing and other areas, but at least we define what that looks like, and now we can build competencies in medical school as it relates to AI education. But I think when you're thinking about Vision 2030 and what's coming up in 5 years, this is an area that to upskill the workforce in terms of being able to use, adopt, think differently, because AI is going to actually change many of these different things in terms of the way we approach things. So I think the AI education is a really key, I don't know if it's a key pillar of the model of care, but I think it needs to be maybe added there in terms of how do we upskill the workforce to be able to do that.
Moving to what our colleague says, is about risk vigilant, being risk vigilant, addressing AI, liberally use it in non-clinical settings, administrative settings, lowering the overhead cost. Definitely that will be risk minimal or free, if I would say. Also assessing the well-being of the staff, predicting signs of burnout early in the staffs, address it early, make sure that will not transform into harm to the patients. So having this tool to be staff-aided, supported, rather than direct patients, maybe it's minimal risk. Having it directly to the patients, you need to be vigilant, definitely. You assess your risk, control it, and that will be, inshallah, hopefully safe practice.
Fantastic, yeah. Absolutely. I think you have to have a lot of those systems in place. So, you know, the regulatory environment to enable it. And I think a lot of people mistake regulation in the AI space. I think the right regulation can actually accelerate AI adoption and technology. Often putting constraints and guardrails in gives people focus and drive, and I think that's probably somewhere where the regulators are trying to catch up a little bit. I think certainly in the US, I know the FDA is sort of playing catch up around the LLMs quite a lot because, you know, the cat's out the bag sort of thing.
I will add one more thing to this. I think AI will help us in transformation. AI is a disruption. So what we need to transform from healthcare's point of view, maybe the AI will be one of the tools that maybe will face some change resistance or require change management, but maybe itself it will be a change management tool because it will push us really to our best, especially if we do it in a very secured environment where we allow some risk, as my colleague said. So I think I look to AI as a soul with two sides. What is really maybe there will be some resistance, but it is also a tool for change management.
So you'd like to see less chief innovation officers and more chief disruption officers?
But absolutely, I think, and there's a key role for infrastructure, whether that be workforce, finding the right use cases, and finding the right environment. So I guess, you know, if we fast forward to 2030, where do you see kind of healthcare and things and these emerging technologies being implemented in sort of routine practice within the kingdom?
I think we have an unprecedented chance to really evolve and to be very ambitious and to maybe lead in certain areas. Especially, we have a very supportive regulatory environment. The whole Vision 2030 is around creating a vibrant society, supporting evolution in healthcare profession and innovation. I think with the empowerment of integration of our system, the right business model of developing the model of care where we streamline and our care to our beneficiaries and make it integral, and also streamline our infrastructure in terms of data integration. In addition to that is the standardization of what we measure and what we really try to improve. So I would believe, Beosh and the audience, with these kind of tools, that's becoming like really a toys sometimes, but it is really a good toys when we talk about developing ourselves or empowering our system or accelerating our strategy. I would believe our chance of success and transformation, even though it's a very challenging task, with these kind of empowerment of tool and evolution around the world every time. We hear about ChatGPT, we hear now about another tool, call it DeepSeek or something like that. So those kind of things we will help to accelerate the change and make sure that we move toward 2030 and we achieve the target before that. And by the way, in other business line other than Health and Kingdom, we achieve the target of 2030, sometimes in 2024 or 25. So I am quite optimistic, even though my colleagues in the healthcare sector, they see this as a very tremendous change. But I'm very optimistic by 2030 we'll achieve a lot of our objective for healthcare transformation.
So I think one of the powers of AI, especially what we're seeing in the United States, for example, is the prediction of disease. So if you're thinking about this from a population health model perspective and the burden of disease in the region, utilizing AI to predict disease, cardiovascular disease, diabetes, what have you, and being able to actually take action before the patient is admitted will reduce costs, improve outcomes. The technology is already there, it's been developed. Now it just needs to be scaled and exported and utilized throughout the globe. But here in the region, I think that would have the biggest impact. If you're thinking about where's the best ROI, where are you going to have the biggest bang for your buck, as it were, how are you going to be able to change the outcome and the needle the quickest? AI prediction of disease, and being able to alert the physicians and the providers that, hey, this patient in 10 days is going to have a bad outcome, and you need to take, the AI will predict and tell you these are the outcomes that you should be taking, or sorry, that these should be the measures that you're taking, and then be able to compare that, as compared to the physician that didn't take the recommendation from the AI, and see what the difference is. And I think as you start to do more and more of this, you were talking about cameras a little earlier, once you start comparing physicians and you're comparing data in terms of what people are doing, AI versus non-AI, that's a game changer, because then it's going to be, why would you want to do care any other way other than AI assisted? And so I think, I mean, that technology is here now. Now it's the question of implementation, and I think by 2030 that could have a tremendous, like a complete shift in terms of the care, the prognosis, the costs, and the outcomes for patients.
I believe is that we are building currently the system for innovation, the system for adoption of technology. Today and tomorrow, maybe we are talking about AI. 2 years after, we'll talk about something else. But having the strong IT infrastructure, strong digital strategy, with the great minds of our investments that we have, we're able to innovate, sustain the innovation, not creating innovation by chance. It's well planned. I think we'll achieve far more than just adopting AI.
No, absolutely. I couldn't agree more. I think, you know, having really critical infrastructure, you know, assessing your data quality, because almost all of these innovations rely on that. And I think, you know, we're sort of guilty a little bit in the NHS. Our data quality is not quite what it should be on a lot of things. We are getting a lot better. But again, it's what you realize is that you try and implement solutions and then you reach these bottlenecks. And I think absolutely, you know, so starting with that scalable approach that will then serve you for, you know, the future, I think is really exciting. And I guess, Dr. Shabab, do you envisage a world, touching a little bit on what Dr. Attila mentioned about, you know, not using AI will be negligent. Obviously, that's slightly controversial, but do you foresee a world where reimbursement may be driven, or healthcare may be sort of driven, and reimbursement models driven by use of certain technologies?
Certainly, I cannot disagree more, Biyosh. I think innovation is the target, AI is the enabler. And I think by fostering innovation through availing chances either to the provider or to the payer is equally important, because I think the payer need to do their best to utilize their resources for the best interest of their population, and also they need to communicate with the provider with the same language. So definitely I think if the payer and the provider mature the same level, aim to the same target, create a win-win situation where they really capitalize on the innovation and the enabler of digitalization and AI, I'm sure the provider will be able to provide a better quality of care, better efficiency, better satisfaction, patient outcome driven. The payer will be able to drive that changes through linking payment to those agreed upon outcome. So I think the innovation here will be equally as important in the way you pay, similarly to the way you render the care.
I think as you move more towards population health, then those incentives will be much more naturally aligned. Kind of going back for a second to your question before, I think that the kingdom is candidly very uniquely positioned and poised just because of the culture. And I think that a lot of the things that we're talking about, when we were talking about model of care, it's really around culture. And I think that today, whether it's the 2030 vision, but this constant idea around transformational change being the norm and the expectation positions the kingdom much further ahead candidly, I believe, than any others. And so, and I think, you know, again, unification at the top and that continuing to flow down. So I think that the elements are here to catalyze many of the things that have not only gone on up until now, but I think many of us are all going to be looking towards the kingdom in the future as the ones who did this faster and better than many others. And so that's my opinion.
Yeah, no, absolutely. I mean, we've heard from Dr. Mohanad that using computer vision to do diabetic retinopathy at scale. I mean, that's something that we've sort of talked about quite a lot in the UK, and it's never really executed or been able to deliver it, certainly not at that scale. So I think, you know, hopefully we've given the audience a bit of a flavour from our sort of payer, provider, and academia around some of these emerging technologies. And I think we heard about a few common themes, certainly that actually it's not just about the technology itself, but it's about enabling innovation and enabling the model of care. And certain technologies are just an enabler to catalyze that a bit faster, but you do need to think about infrastructure like data quality, workforce, and how all of that can be addressed to be able to execute on that plan. So thank you very much for your time, and hope you enjoy the rest of the conference. It's been fantastic so far.
Thank you very much for that insightful discussion. After a full day of discussing innovations in healthcare and transforming a legacy model of care delivery to a more agile, integrated healthcare system, we cannot conclude the day without addressing workforce readiness and development. This session, with its expert panelists, will highlight training, upskilling, and the future needs of healthcare professionals in integrated care models. Moderating this session with decades of experience in healthcare strategy and transformation and current Chief Medical Officer of PwC Middle East, please give a warm welcome to Dr. Richard Jenkins and the distinguished panelists.
Hi, good afternoon. I think we're the last show in town, so hopefully we'll make it entertaining for you. Thank you for staying. We're going to cover what I think is arguably the most important component of the day, which is workforce. My name is Dr. Richard Jenkins. I'm Chief Medical Officer and Senior Executive Advisor for PwC Middle East. I'm a family medicine specialist by training. I've lived in the region for the last 12 years and live in Riyadh, so very much part of your exciting healthcare journey. Why do I say that this is the most important panel? I think we've heard about technology, we've heard about strategy, we've heard about metrics. None of this happens without the people. You know, healthcare is a people business. We need a capable workforce and a capable workforce at scale to do all of the things that you've heard about today. And so I've got a great panel. Dr. Ziad Naqshbandi, CEO, National Center for Workforce Planning at the Saudi Commission for Health Specialties. Dr. Issam Albanyan, Chief Education and Training at KFSH. And Professor Steve Field, who's the Prime Minister's Special Healthcare Representative to Saudi. I'm going to start with you, Dr. Ziad, and try and set the stage. We're heading towards 2030. We're heading towards a new model of care. In terms of workforce and workforce planning, how should we and you plan the workforce so that we can enable and empower the system to deliver the requirements of 2030 and the requirements of an integrated model of care.
Thank you very much. Good afternoon, everybody. Thank you, Richard, for this introduction, and it's a great honor to be with you. I would like to thank the scientific and the organizing committee for the kind invitation. I think you touch bases upon one of the most important things that we need to articulate all of our planning for the future when it comes and it touch bases with the Vision 2030. I think we do understand, and we've heard probably before, that we have three main pillars related to the Vision 2030. The vibrant society, the thriving economy, and the ambitious nation. When it comes to workforce planning, I think the first two are very important to us. When it comes to vibrant society, the overarching objectives of that is offering a fulfilled, healthy life. And when it comes to thriving economy, I think the aim of the overarching objective is to increase the employment. And if we move to the strategic objective of each one of these two, we can find that increasing the access of care and increasing the value of care need to be aligned very well with the vibrant society pillar, and increasing the readiness of youth to indulge into the market, which is the health ecosystem, and also making sure that the educational curriculum meets the market needs and demand is going to be very important. So I think those are, in general, the mapping that we always look to when it comes to the Vision 2030 and its pillars, and how can it be articulated whenever we do a sort of a planning. I think probably you touch bases upon the challenges that the ecosystem is facing right now. And I think I can summarize those, which is not explicit for our ecosystem. It can be on a global basis, but I can summarize them into main 8 challenges. Number 1, the ever-changing demographics and burden of diseases that we need always to articulate our plan with. The second is the rapid technological advancement. We were speaking about the advancement in AI, the machine learning, the blockchain, Internet of Things. So all of these kind of skills we need to incorporate into our future generation of healthcare workers. The third is the changing roles that we're seeing in health system. Probably we're used to the old traditional ways of looking to the educational curricula. This needs to be changed. It needs to be personalized to meet the demand of the market, and some of these roles need to be shifted so that we can have a sort of a resilient, flexible workforce that will meet the demand and the need of the market. Also, one of the most important things, and I think we were speaking about it, is the data. When it comes to workforce, we need always to have the data available, and we need to have a valid data, because you cannot plan without having these two accurate measures being implemented. I think if we moved also, I think addressing the shortages and maldistribution of healthcare workforce is going to be also a very important element. Addressing also the appropriate skill set and mix is going to be something that we need to integrate into our future generations, because working alone now in a profession is not going to be the key answer. We need to work in an integrated, a sort of intercollaborative fashion to meet the tomorrow's need that we need to articulate our plans to. And probably having all the stakeholders working in an integrated manner, collaborative manner, to set the agenda for tomorrow's workforce is going to be very important. And finally, I think we cannot work in a segregated silos where each entity or sector have their own kind of workforce planning. We need to have a sort of a unified plan that meet the alignment of Vision 2030. So that's in brief where I can see and look to the Vision 2030 and the challenges that the system faces at the moment.
Perfect, thank you. And I think that notion, we've heard it today, the pace of change is both rapid and relentless, and that pace of change impacts workforce throughout. Dr. Issa, I'm coming to you. I qualified in 1996, which seems a long time ago. The world has changed since then. I think of the students who are entering education now and those who are entering residencies and internships, and how different the world will be in the future. How do we deal with that? How do we look at reform and adapt our education systems, our continual professional development systems, so that the workforce of the future is able to deal with all of these changes that Dr. Syed has mentioned and deliver the model of care, deliver the quality and the volume of care that we're going to need in the future?
Thank you. Appreciate it, Richard. Again, I thank you all for the invitation, and it's a pleasure to be here, an honor to be amongst this distinguished group. Richard, thank you for that question. I think it's a very important question. No doubt that there's been a lot of change or improvement in how we train residents here in Saudi Arabia, in particular, the undergraduate, the residency programs, and a lot of excellent work done to try to improve and graduate physicians who are prepared for some of the changes you mentioned. And the Saudi Commission for Health Specialties has been doing very aggressive work on the changing the curricula and so on. And I think a lot of good things have happened. However, the pace of change is just too rapid. And I think we still have a lot of work to do and look at it very differently in how we educate our future physicians, nurses, and allied health practitioners, those who deal anybody who deals directly with patients. And I think the biggest concern is that I see is that they're not well prepared for the integrated model of care that we've been talking about all day today. I think we still train our trainees, our students, in a very siloed manner. And I think the first or the best thing we need to do, because the change of pace has not affected only the medical world, but even our patients. And I think the very first thing to do is really have a deep understanding of what our patient need, and something that is not just based on physicians and not a physician-centered approach, but really understanding what our communities need. And with the technology today, that's not something, it's very doable to understand more what our patients need. In addition to what we see with the current changes, we heard the session today about artificial intelligence and all these new technologies, determine these new competencies that actually focus on integrated care and really transforming how we educate our trainees into a competency-based model. And true competency-based, that actually throughout their career, not lectures or sessions on what is competent, but really look at competencies throughout their pathway, throughout their journey, assess these competencies, make sure they attain them, these skills that are directed towards these outcomes that would result in integrated care, and really meet the needs of our society, and break down the silos. We still rarely, I don't know what your experience is maybe, but we rarely see physicians and nurses and allied practitioners actually learning together or practicing together. We hear a lot of talk about it, and maybe a session here or a session there, but true bedside integrated teamwork care, or in a clinic or an outreach clinic where people are working together, it's usually very physician-centered, and I'm a physician. And that's really not the way the future is going to look like. We heard the session today about the experience in New York and Chicago and Houston, and that model will never work with a physician-centered type of care. And so if we can introduce this type of competency-based training into our curricula, assess it well, and embed interprofessional training, which I think we're getting there, but we're still not there. It will make a huge difference on how our graduates are able to deal with the changes. I use a model, I love taking my BLS. I know many of you have to renew your BLS. And that's probably the best model where we see true teamwork. It's a small model, but if we can expand that to how we actually deal with whether it's tertiary care or primary care, and develop models in the training journey at the bedside and integrate technology into that. And I use it cautiously. We just heard the session just now, and often technology is integrated or let's say just use the word purchased because it's fancy and sounds really good to have this technology. I'm not going to even use specifics, but integrating technology where we can use it to track our trainees and the impact and the outcomes real time. And that way you can make interventions quickly in your curricula to make sure that you don't wait till the end of the year to see if there are pass-fail rates or the end of the year report to make changes in your training journey. And at the same time, all the things we heard today about implementing predictive AI models for diagnostics, for some really amazing stuff on how to take care of population health. But if we don't train our trainees how to actually use those and incorporate it in their practice, in the end, it may not be as powerful as we think it might be. So I think really embedding that. And then looking at those who are already trained, like myself, we need to do our continuous professional development model a bit differently and include some of these competencies in that. These are a few points, and I'm aware of time, but I could talk about this for a long time.
Yeah, and I think it's like so much in medicine and healthcare. When you talk about it, it just seems so obvious. Why do we talk about team-based care, but we don't train people how to work in teams? It's clearly an opportunity for us. Steve, I'm going to pose you a challenge, and that challenge is we're entering an integrated model of care future, and you have the opportunity to reshape what the healthcare professional workforce looks like from the ground up. You can change the current professionals, you can bring in some new professionals, you can build some teams. What do you think the gold standard or exemplar primary care and wider health professional workforce looks like that will deliver an optimal integrated model of care?
Well, thank you, Richard. I must say, just to be clear, my background is as a family physician, so to declare a bias. And as a dean, I was responsible for a large region in the UK, responsible for nurse, doctor, physio education, of which integrated education was right at the top of the agenda. I've been coming back and forth over 5 years here, and have been involved in the model of care for all of those 5 years. And I must say, I am hugely impressed with the opportunity that the model of care provides to define the system that you've got from the bottom up. But the most inspirational meeting that I've had in the kingdom over those 5 years was yesterday. And that was with Professor Orr's General Secretary here at the Saudi Commission for Health Specialties, because he basically gave me the answer to your question, but described all the work that's been going on, particularly in the last 6 months to a year. And that's around competencies. It's about recognizing the importance of professions, understanding that most of the workforce that's going to be here for the next 5-10 years are already here. It takes at least 5 years to get doctors into the system. And I was really impressed with the changes you've got here, looking at general medical practice training, family physician training, which basically is what I did for a job back in 2007 when we wrote and launched the GP training curriculum in the UK, which has allowed general medical practice to move forward. So what I would say is you need to work out what the competencies are to start with, and then link them to existing professionals. Link those to what you need from the model of care. And then you can start to work out what the workforce need is as a whole. So looking at primary care, the UK has a really good model of primary care, but it has to change. The Dutch have a great model of primary care, and it's evolving. Probably the best model that I've seen around the world is at Group Health up in Seattle, where they have a team-based approach, which was similar to our own practice, where you have a manager, you have a number of doctors, family physicians that are needed for a set number of patients, nurses, physicians associates, a doctor that works in the hospital on behalf of the practice. But you start with a model like that with a team-based approach with the patient at the center. You use technology and AI as it develops as much as you can, and recognize all those roles will need to change. So just as important in the training is the CPD. And I'm with you, my favorite training of all in a practice linked to the military was basic life support, where you spend a couple of hours on the floor with the receptionists and the nurses and the doctors, and you really learn and joke together. And the more we can do that for the patient, the better.
Yeah, absolutely. Thank you. Dr. Zed, you mentioned earlier some of the challenges around the need to be adaptable, the rapid pace of change, the siloed working, the opportunity and the challenges for 2030. Now you have the enviable task of planning a workforce that's going to deal with that and manage that. Within workforce planning, where do you see we have gaps at the moment? Where do you feel that we're not quite getting the entire picture? Where are the holes in your planning? Where are the opportunities in your planning? And how would you prioritize how to identify those gaps and to close them so that we don't just understand what we need today, we understand what we need tomorrow, 5 years, 10 years ahead of us?
Sure. So I think this needs to be started with a scientific basis and scientific approach to the issue. Through a work that we did in the center over the past couple of years, we tried to analyze different kind of aspect in the ecosystem. So we did a current state analysis, we did a benchmarking analysis, we did the stakeholder analysis, and external environment analysis, and we came up with 5 main perspectives or gaps in the system that need to be addressed in order for us to have the proper kind of workforce planning for the future. The first is having the right appropriate governance model that will incorporate all stakeholders in the ecosystem. And when we speak about the ecosystem in health, that's not particularly or necessarily pertain to health only. We need to incorporate the education and training arena. We need also to incorporate those who are involved with the market, and also those who are financing the training and the practice. So all of those need to come together and set up the future North Star for health workforce planning. Secondly is data, and I think we have highlighted the importance of data. We're not speaking here about practitioner data, but we are speaking about geographic distribution, we're speaking about their qualifications, we're speaking also about clinical decision data that might affect tomorrow's world when it comes to workforce planning, in addition to the productivity, effectiveness of the system. So all of these data need to be integrated together and also built into a system where you can forecast and project for the future. Thirdly, I think identifying the gap between the demand and supply in a demand-oriented approach, because what we used, or when it comes to the educational system, they focus mainly on the supply side and ignoring what does the market needs for the future. So I think a demand-oriented approach to balance the gap between demand and supply is very important. Fourthly is the capability building. And I think Dr. Isam rightly touched about how we need to equip our tomorrow's generation with the right tools, not necessarily qualification, but experiences and skills that will meet tomorrow's world need. And finally, I think understanding the policies and bylaws that need to be mitigated in order for us to have a sort of a resilient workforce that will adapt for tomorrow's world. So I think that's probably a big kind of chunks of the major gaps that we see. How these gaps are articulated with the system, I think probably we need to look towards balancing the gap, increasing our national citizens to be more incorporated into health field, addressing the challenge of attractiveness and retention in the workforce, and making sure that we have a resilient workforce that can adapt to multiple roles as we move on through this transformation. I would probably end up by saying that in order for us to determine the priorities of the demand, we need to focus on three important elements. Number one, it needs to be articulated with the Vision 2030, as we mentioned. So we need to articulate with it the global and local trends. Secondly, we need to understand the population and spatial policies that probably will touch bases on the market as we move on. So we need to understand the population health mandate, the burden of disease, and how this is going to contribute to our tomorrow's planning for workforce. And finally, I think we need to understand the market dynamic aiming towards a value-based healthcare, having the best quality of services with the lowest cost.
Great. And I think that capability for having that broad brush look, and as you said, we can't just look at supply or demand, we have to look at supply and demand. Dr. Isam, I'd like to focus our attention on leadership and the role of leaders within the healthcare professional groups as we move into this time of change. And nobody likes change. I think healthcare doesn't like change particularly. It's quite slow to adapt. And we need strong leaders who are going to bring this model of care forward and take us to where we need to go, take people with them. Do you feel that currently we have the right level of education and support or potentially mentoring so that we can identify future leaders, we can pick them up, we can bring them through, and the leaders that we do have, we nurture and we provide the ability to lead so that we can get to where we're going?
Thank you, Richard. I think it's a challenging question because I think the short answer is yes, we have some great leaders, I think, who are already leading the initiatives. We saw many of them today and who are doing some great work. I think the issue is exactly what is expected of them, and especially if you talk about the future leaders. What's expected of future leaders might be very different than what's expected for our current leaders. You mentioned some of the challenges earlier, and I think empowering or embedding in our educational system leadership skills that are, I hate to say the word predictive, but at least make an attempt to predict what kind of competencies our new leader will require. Many of our leadership education models rely on sort of financial ability or the decision making, et cetera, cultural change management, which are all very important. But when you talk about model of care and healthcare in particular, and then I think the major topic that we've been asked to address is the integrated care, integrated model of care. I think many of our leaders, especially in the educational world or institutions who are responsible for trainees, that concept still has not sunk in yet. And I think for our future leaders, it goes back to that competency I mentioned, that it should be included in their training and embedded. And this is what the work we're doing with the Saudi Commission right now is actually revising our curricula to work on preparing these future leaders. Now, again, not every trainee is going to be a leader. And we actually are trying to make career pathways for some of our trainees now, those who want to be leaders or those who want to be scientists or more going to career path of education. Because again, it used to be a broad brush that everyone learns about leadership, research, education. I think this model is probably not going to work as we move forward with very highly specialized areas of healthcare delivery. So I think we need to be selective, and those who want to become leaders, invest in them, invest in these new competencies to prepare them for the changes you mentioned earlier in the beginning of this session. I think it has to be done because if we don't prepare them well, it'll be difficult to meet our goals. And integrated care, I think, has to be a KPI. When someone takes on these positions and expected to change the model of care, leaders sometimes are driven by KPIs to show how you're establishing or using a integrated care model, a model of care. Yeah. So I think these are some of the points I'd like to highlight when I talk about leadership.
Yeah, agreed. And I think it's going to be critical we have capable leaders and people who want to be leaders. You know, that it has to be attractive. Steve, and come back to you and primary care. I mean, we both have a bias, but I think it is fair to say that most models of care have primary care at a foundational level. But as Dr. Issa mentioned, we can't just have primary care and secondary care and tertiary care. We have to have integrated care. How can the kingdom continue its journey to build primary care that's capable and at scale, and that also integrates into that wider system, so that we don't just end up with a new primary care function that's still not integrated into the wider thing? So as a patient, I don't really care whether I go to primary care, secondary care. I'm on a journey to better health. How do you see those two things coming together?
Well, first of all, here there's a dire need for family physicians. The numbers are very, very small. I'm delighted that the number of training programs is increasing. And the idea of rapidly increasing the training and getting GPs out into the workforce is really important. But that needs to be augmented by a new model of nurse training, which includes advanced nurse practice in primary care, with many nurses doing the role of GPs. And indeed, one of the big untapped resources in the kingdom are the pharmacists. In the UK, we now have pharmacists doing an extra year training with more clinical work, and all doctors, all nurses, all pharmacists can now prescribe. But to get the integration between primary and secondary care, I think we need to let specialists have a better understanding of what primary care means, which means all of their training needs to involve some time in primary care to understand the pressures. The more you become specialists, the more narrow your focus is. In general medical practice, you're meeting people for the first time. Their symptoms are often obscure. You don't have as quick response to getting investigations as in hospitals. So a better understanding of both sides, I think, is really, really important, and more training together. So if you're looking at diabetes, I was on the Mecca cluster board for a while, and diabetes there is such a major problem. That training needs to be across professional groups and indeed with patients, and it's the patients that really need to be empowered. But I think you can do that as you move forward, with GPs also having special interests in hospital specialties. The better you get people working together, the more you get understanding, the better. And then going back to leadership, one of the really good things we've got in the UK for medical training is grabbing a select group of trainees at a regional and especially national level and putting them on special fast-track leadership courses early on, so that it's wired into their brains, rather than doing it when they finish their training, where they're really focusing on their specialty or on general medical practice. So I think it's all the simple basic rules of learning together in a multi-professional way, which is key.
May I add?
Please.
I just wanted to add one about the GPs and family practitioners and the specialty care. It's just a model. We just started this at King Faisal Specialist Hospital. I think it really hits exactly what you're talking about, Professor, is that we started a precision medicine clinic that relies on genomics. You think that this is run by geneticists. It's run by family physicians. This is a family physician-run clinic. And it's a team with the nurses who've been trained. We have the genetic counselors, we have the pharmacogenetic team, and the back end, of course, our genomics center is sort of the back end that does some of the lab work, but it's really run by the family physicians, and they're really keen, and they're so excited to run this precision medicine clinic. And so it's really, we hope it'll work. I mean, it's really, getting specialists and primary care people working together is not easy, but if it works, I think it'd be a great model.
So building on that, really, what is the most important thing for primary care and nursing is that GPs, family physicians, are respected for the job they're doing and how difficult it is. The big problem we've had in the UK and in other countries that have GPs, family physicians, is when medical students go through their placements as students, the language and attitude of hospital specialists and consultants is very much derogatory towards GPs and nurses often, and they don't understand how difficult the role is. And I personally, even though I led our own college of GPs, still, and have had specialists saying, well, you're only a GP. Don't worry, you can become a GP if you don't make it as a surgeon. Well, frankly, general practice is, family medicine is one of the hardest jobs you can possibly do. And a bit more respect and across the profession would be hugely useful as well.
I agree with this, and maybe Ziad, you come in. Here in the kingdom, though, I think, and being in education, there's been a shift in that. And I look at the application process. Actually, family medicine, there's a huge number of applicants for family medicine, because I think how the kingdoms looked at family medicine physician, the Saudi Commission, what's the accreditation, the standards, they actually have the best standards. Now they're leading in AI and introducing AI into their, and I think there are opportunities in the kingdom for family physicians is increasing, whether in leadership or other areas. So I hope it's changing.
So we should see them leading on model of care, and up on this stage, your own family physicians, because role modeling is so important. So we need to see it physically, hear it, and make it happen. You've got a massive opportunity with the model of care to really make this the best system in the world. You really have.
Absolutely. We've got 2 minutes, and I just open it up to the whole panel, something that we were talking about before the panel started, and that's the reality of the war on talent when we talk about workforce. And I think that's now a global war on talent. There is a global demand for nursing that is insatiable. There is a global demand for skilled specialists, and we're short of general practitioners and family medicine. Just a closing comment, how do you in Saudi Arabia grab that talent, attract that talent, and retain the talent so that you can use that to deliver the healthcare that you need in the kingdom?
I'll tell you, I mean, that's a very difficult question to answer in less than 2 minutes, but I'll give just my take is that I think what Professor Steve mentioned about creating this environment that people can be proud of working here, whether you're a family physician or a skilled or a nurse. And someone mentioned the fourth now, remember the fourth objective, and is actually well-being and the workforce really being engaged. If we can succeed, we're not there yet, but if we can succeed in making Saudi a place where a healthcare provider is happy to work in and proud to work in and can see the outcomes and be engaged, I think that's probably the biggest step, and a few other things. But
agreed. I think we've forgotten about pride and purpose in our careers. Doctor?
Yeah, thank you. If I may add to the point of well-being, I think this is a very important element that we need always to keep it in mind. The health field is started to be a little bit less competitive as compared to other easily applicable tracks for people to get in, especially when it comes to junior generations. So I think increasing the well-being is going to be one of the most important factors that will attract and retain people, especially when it comes to nursing. And I think there are 4 important factors that we ought to focus on. Optimize the resources. So when it comes to staffing, for example, when we come to the working hours, this need always to be considered. Secondly, I think it's very important to look to the mental health aspect of our practitioners, how we can provide the best environment for them to work without the pressures that they are facing, especially when it comes to electronic medical records and all of these AI tools that they need to work with at the moment. So that's also a very important element. Thirdly is the leadership. I think we spoke a lot about the leadership, but it's a change agenda that we need to adapt. How are the leaders going to adapt well-being as part of their change culture? And that's going to be a very important. How they're going to incorporate psychological safety in their workers is going to be something that we need to put a lot of emphasis. And lastly, probably the workplace itself. how we can have the most attractive workplace for people to work in together, how we can have bylaws for workplace to be as friendly as possible for people to work in. So I think focusing on the well-being of our practitioners is going to be a very important element.
Great. Steve, last 30 seconds from you.
Of course, all of that. But my observation on nursing in the kingdom is you need a pay scale which rewards the nurses from the start of graduation through their careers, which rewards them becoming advanced nurse practitioners, and that will help retain and recruit, not just from Saudi Arabia, but from around the world. But the pay scale is lacking at the moment, and it needs to be universal across the whole country.
Great. Thank you so much, gentlemen. Please show your appreciation for the panel, and thank you.
I want to thank the attendees who are still with us. I mean, thank you so much for being here and your dedication. Thank you.
Thank you.
Thank you very much to the panel for your insights. We had a rich day of content, all revolving around the transformation of the care delivery model, talking about how and what needs to be done in order to achieve a healthcare model that is best suited to deliver the best care to elevate the health and well-being in a population. The stage was set with the local journey, and then we took and heard some perspectives, international perspectives and global perspectives and innovation on how others have gone through their model of care transformations. We've had cross-sector healthcare leaders going through the model of care transformations at various levels, talking about their challenges, agreeing on the importance of communication and collaboration. We've also heard of the lessons learned across the local ecosystem. We've heard about the leadership qualities that are necessary to achieve the transformation and the model of care that we are striving for. We've heard of the importance of learning health systems to drive scalable and adaptable care implementation. We've heard about the importance of identifying and measuring metrics and KPIs to be able to track the progress we have and to know that we're going in the right direction and to know when to stop in areas that we may be investing more than need. We've also spoken about, or we've heard about, the importance of leveraging AI and big data to enhance delivery through personalized care, and it ended with the vital role of workforce readiness through upskilling and planning. Today was a rich day full of content. Tomorrow will be as rich as today, starting off the day with a discussion around the science of integrated care implementation and the integral role of primary care. There is more on that agenda. What I want to make sure that we do before we conclude the day is want to end it with a round of applause for three. First, the audience that was present throughout the day, not only for your presence, but also for the care that you do in your contribution to the health of the population and the transformation. Two, for all the panelists and speakers for enriching all of the audience and us with your expertise and your insights. And three, to the organizing committee that has spent many, many hours to make this day as successful as it was, hoping as well for a success in day two. Thank you very much.